in Heart Valve Update 2022. Now I would like to invite Chairman RHL Heart Center, Dr. Ravindra Singh Rao sir, for his welcome speech.
Good evening, everyone. I welcome you all for this heart valve update, and let me tell you, your presence is going to make it success. But most importantly, I would like to welcome Dr. Gautam Sen sir and madam, who could find some time and come and attend this program and bless us. Those of you who don't know, Professor Dr. Gautam Sen is the first cardiothoracic surgeon of Rajasthan, and is a pioneer in building the cardiothoracic surgery program in Ajmer Medical College and most importantly, SMS Medical College. I would also like to welcome Professor Dr. Dev Guru, who is a cardiothoracic surgeon in All India Institute of Medical Sciences, Delhi. Dr. Manish Bansal, who is the head of non-invasive cardiology in Medanta. And all my friends and colleagues, Dr. Gandhi, who is the head of cardiothoracic surgery at Gitanjali Medical College, and who has been pioneering in doing complex cardiac surgeries as well as transcatheter valve, Dr. Ram Chatlangia, Dr. Ramesh Patel, and all the cardiologists and cardiac surgeons sitting in the audience. And this gives me immense pleasure and hope and happiness that in near future, Rajasthan will be one of the hub for transcatheter valve therapies. And we were discussing that 5 to 10 years down the lane, this therapy is going to grow and majority of our patients are going to benefit. I would also like to welcome Dr. Sanjeev Sharma sir, who is a Director of Intervention Cardiology at Eternal Hospital and expertises in doing complex coronaries and structural heart disease work. And also Dr. Sanjeev Sidana and all my friends, Dr. Brijmohan Goyal, Dr. Ravi Inania, who has come all the way from Jodhpur. I welcome you all. So without wasting any further time, because we have a very exhaustive program, and also have Professor Gokru, who is the head of department of Ajmer Medical College, pardon me, sir, and Professor Dr. C.B. Meena, sir, who is again from SMS Medical College, and leaders in their field, and they have also been my teachers, and they have helped me during my DM cardiology and further career. So without wasting any time, I think we will start with the program right away, and looks like we're trying to make an academic and an program. So I think I would also request all the speakers to stick to the time so that we can have more discussions. Again, we decided, Dr. Buddhaditya and me, we decided to have a combined cardiothoracic and cardiology program because as we are marching forward, heart valve therapy and these patients will be seen by both cardiologists and cardiac surgeons. And such a program will help us to make the right decision for the right patient. Thank you all, and I welcome you all.
Thank you very much, sir, for your warm welcome. For the first scientific session, now I would like to invite Honorable Chairperson on dais, Dr. Ram Chitlangia, Dr. Dinesh Gautam, Dr. C.B. Meena, Dr. Ravindra Singh Rao, Dr. Buddhaditya Chakravarti. May I request to all of you, please join us on a stage, Dr. Ashok Garg and Dr. Sanjeev Sharma. May I request to all esteemed chairperson, please come on a dais and chair the session. Now, I would like to hand over scientific session to Honorable Chairperson.
Good evening, welcome everybody. And I think we'll start and we'll have the first talk on the eco-evaluation of aortic valve disease beyond gradients. Dr. Manish Bansal, and he is well known. He is head of the non-invasive cardiology at Medanta Hospital. Dr. Manish Bansal, please.
Good evening, everyone. It is an absolute privilege for me to participate in this meeting, and I belong to Jaipur. So that is another reason for me to be absolutely delighted to be here. And I thank Dr. Ravindra Rao for giving me this opportunity. It's
Dr.
been-
Manish, if you permit me, I can tell you something about you from my side. Dr. Manish Bansal, I know him since last, say, 28, 29 years. Together we fought pre-medical test, and you must be knowing Dr. Manish Bansal was topper, first rank in Rajasthan PMT. In All India PMT, he was 5th rank. He did his MBBS from Maulana Azad Medical College. Later on, he did his MD medicine from All India Institute of Medical Sciences. So I just later on did his DNB cardiology from Escort Heart Institute itself, and he has got so many publications with I can say more than 100 publications with original articles in various guidelines. So overall, what I want to say, he has excellent excellent academic career throughout his this time. So I am sure he's going to a very beautiful and excellent talk. Thanks.
Thank you for this kind introduction. So we'll start with the topic straight away. We know that the understanding of aortic stenosis has evolved considerably over last 10 to 15 years. We understand it well today that aortic valve gradient is only a small part of the whole problem, and gradient may not be always dependable. To highlight this, I'll begin with the case. This was an 84 years old gentleman, hypertensive, diabetic. He had triple vessel disease on medical management. He also had B-cell lymphoma, presented with grade 2 dyspnea, underwent echo. Echo showed normal LVEF. Aortic valve had some degree of narrowing, and there was gradient. Mean gradient was 21 millimeters of mercury. So one would be tempted to call this as mild to moderate aortic stenosis just looking at the valve gradient. But if you look at the valve, this valve is heavily calcified. It is hardly opening. And if we estimate aortic valve area using continuity equation, the valve area was only 0.8 centimeters square. So this was actually severe aortic stenosis, not really a moderate aortic stenosis. And this is something which we need to always keep in mind, because we know that the guidelines recommend that AS should be termed as severe if valve area is less than 1 centimeter square and mean gradient is more than 40 millimeters of mercury. But in nearly 1/3 of all patients who present with significant aortic stenosis, there is discrepancy that the valve gradient is less than 40, even though the valve area is less than 1 centimeter square. So unless we estimate valve area, if we only look at valve gradient, we will never be able to pick this entity, which is very, very important. And if we start measuring aortic valve area as a routine, we'll be able to classify aortic stenosis in a variety of hemodynamic subsets. Of this, here on right hand side we have patients who have low gradient AS, so valve area less than 1, gradient less than 40, and as I said, this occurs in 35 to 40% of all cases of severe aortic stenosis. So the main reason why these patients have valve gradient less than 40 in spite of having valve area less than 1 is that valve gradient is flow dependent. So these patients have reduced stroke volume, which is the reason for low gradient. Now reduced stroke volume itself can occur in two conditions. One, when there is LV systolic dysfunction, EF is less than 50%, so we understand that because there is not enough force, there is reduced stroke volume and low gradient. But importantly, this can also occur even in the presence of normal LVEF, as the case I showed. There we call it paradoxical low flow, low gradient, severe aortic stenosis. So this entity we'll be able to diagnose if we measure stroke volume as a routine. So in every patient in whom we suspect aortic stenosis, we should measure aortic valve area. We should also look at stroke volume, index it. If it is less than 35 ml per meter square, it indicates low stroke volume. Some investigators tend to use flow rate. So there we take stroke volume and divide by ejection time to get flow rate. If it is less than 200, that indicates reduced flow rate. Now, how we investigate this further is a separate entity, but before that, we need to remember that presence of low flow itself is a poor prognostic marker. Whatever may be the mechanism, if flow rate is reduced in a patient with aortic stenosis, it indicates poor outcome. and these patients benefit from early aortic valve intervention, whether it is TAVI or surgical. TAVI obviously improves outcomes significantly more because of its low early operative risk, procedural risk. So when we are faced with a situation where valve gradient is low, stroke volume is low, valve area is less than 1 centimeter square, we may use dobutamine to see what happens when the myocardium is stimulated. If it is truly severe aortic stenosis, gradient will increase more. If it is not a severe aortic stenosis, valve area will increase more. So here we have an example. In this elderly gentleman, valve area was 0.9 centimeter square to begin with, mean gradient 21. On dobutamine stimulation, valve area increased to 1.1, gradient increased to 34. So this was more of a moderate aortic stenosis. But the role of dobutamine echo has also become quite limited with time, because studies have shown that even in these patients who have got almost moderate AS with LV systolic dysfunction, early intervention benefits. I'll come to that. Now, when LVEF is reduced, stroke volume will be low. That is understandable. But what could be the mechanism of low stroke volume in the presence of normal LVF? So there are a variety of reasons why stroke volume can be low in these patients. This may be because of hypertrophied ventricle with small cavity size, so the overall volume is low. There may be subclinical LV systolic dysfunction, or there may be increased afterload on the left ventricle because of uncontrolled blood pressure, or increased arterial stiffness, which we can quantify using this term, estimating this term valvulo-arterial impedance, which is not only a reason for low stroke volume, but also a prognostic marker. And then in these patients, another very important modality is to look at aortic valve calcium. If aortic valve is heavily calcified, then it is likely to be severe aortic stenosis, whatever may be the gradient. And again, in these patients, aortic valve intervention helps. So in paradoxical low flow, low gradient aortic stenosis, we need to put multiple things together: patient's presentation, condition of the myocardium, extent of hypertrophy. We may use dobutamine here also, aortic valve calcification, to come to a conclusion about the severity of aortic stenosis. So that is one part of the problem. We determine severity of aortic stenosis by not looking at not only gradients, but valve area, flow, and flow rate as well. The other very important part of aortic stenosis assessment is to look at the impact of aortic stenosis on the heart, various chambers of the heart. And in fact, a staging system has been proposed which quantifies or recognizes upstream damage caused by aortic stenosis. So stage 1, when there is LV damage; stage 2, when there is damage to LA or mitral valve; stage 3, when there is damage to pulmonary valve, vasculature and tricuspid valve; and stage 4, when there is damage to RV also. And as there is increasing severity of damage, prognosis worsens. So the impact of aortic stenosis on the LV myocardium and upstream chambers is also a very important factor that we need to take into consideration. But of all these chambers, impact on LV myocardium is the most important, because it is one of the strongest determinants of outcomes and also an important trigger for intervention. When there is LV myocardial dysfunction, we offer intervention in these patients, whether it is SAVR or TAVR. So now we know that aortic stenosis is a condition which is associated with increased LV afterload, which leads to LV hypertrophy, which is initially compensatory mechanism. With time, it becomes maladaptive. There is myocyte necrosis, fibrosis, which leads to eventually myocardial dysfunction. Cardiac MRI is actually the excellent modality, best modality to look at all these events that are taking place in the myocardium. We can quantify myocardial fibrosis, expansion of extracellular volume, which has a strong prognostic value. And for that reason, we now have a trial, a randomized trial, which is looking at benefit of early intervention based on MRI findings of LV myocardial damage in asymptomatic patients. But MRI is something which we cannot do in every patient. So what we can do if we are using echo? So on echo, global longitudinal strain has emerged as a very useful modality. Global longitudinal strain is a good surrogate marker for myocardial fibrosis. It's been shown in studies using MRI that it has excellent correlation with the extent of MRI detected fibrosis extent. And for that reason, it has strong prognostic value. The good thing about GLS is that it becomes impaired much before LVEF drops. So we can see one example here. This is a patient who's got severe aortic stenosis. As you can see, gradient is very high. LVEF is normal, 59%. But if you look at LV strain, it is already significantly reduced, roughly around 15%. So there is already an evidence of myocardial dysfunction which we are not able to pick up if we are looking only at LVEF. This is another very important study. Looked at 294 patients with severe AS for all-cause mortality. So here we have curve which shows patients who had normal EF and normal GLS, and here we have patients who had impaired LVF. Now look at patients who had impaired GLS but normal LVF. Their prognosis was same as patients who had impaired LVF. And in fact, a recent meta-analysis which looked at 10 studies showed that GLS is a stronger predictor of outcomes in these patients as compared to LVEF. And when GLS value decreases below 14-15%, mortality increases all of a sudden. So there is an inflection point here, which is an important threshold. Now another very important point is that LVEF, I showed you that GLS is a stronger predictor of outcomes, but LVEF has another problem. We have been using 50% as the cutoff for LV systolic dysfunction in aortic stenosis. But that is actually very, very late in the progression or natural history of aortic stenosis. This is a very, very important paper from Mayo Clinic. 2017 patients who underwent AVR and then they were followed up for all-cause mortality. So patients whose EF was 60% or above, their outcome after AVR was same as for general population. But those whose EF was 50 to 59%, they had significantly higher mortality even after AVR. And those whose EF was less than 50%, their outcome was definitely much worse. So this means that we cannot wait for EF to fall below 50%. Now there is another very important paper and worrying thought in fact. This is a recent publication again from Mayo Clinic which looked at nearly 1,000 patients who had presented with aortic stenosis. At presentation, 20% patients had EF less than 20% and 80% had EF above 50%. So if you look at this, the upper two charts here, these are the patients who presented with EF less than 50%. So in them, their EF decreased when their valve area was 1.2, not 1, which means that those who are destined to develop LV systolic dysfunction, they develop LV systolic dysfunction even when aortic stenosis is moderate. So this means that moderate AS, LV systolic dysfunction is not a benign entity. These are the patients who are going to develop much faster LV systolic dysfunction in near future, and they need to be treated aggressively. And this is complemented by this retrospective study from Korea, which showed that the patients who present with moderate AS and LV systolic dysfunction, early AVR significantly improve outcomes in these patients. And for this reason, we have two trials, randomized trials currently undergoing, TAVR Unload and Progress, which are randomizing patients with moderate AS, LV systolic dysfunction to early intervention. And once we get results of these trials, we might be treating patients with moderate AS also, not waiting for AS to become severe. And lastly, in any patient who presents with low gradient, low flow AS or LV systolic dysfunction, we should always look at the possibility of amyloidosis, which is very common. Overall, roughly 15% of patients with severe AS and roughly 30% patients of low flow, low gradient AS have cardiac amyloidosis. And finally, in any patient with AS, we also look at the common things like etiology of aortic stenosis, aortic root anatomy, condition of the aorta. For all this, echo is not the best modality. We know CT is the one that we go for, and this is something which is going to be covered in the next talk. So to summarize, accurate assessment of AS requires comprehensive evaluation of the AS severity as well as LV myocardial response to it. Valve gradient is flow dependent and hence not reliable. Estimation of AVA and transvalvular flow is essential for complete assessment of AS severity. And it is also equally important to assess the status of LV myocardium. For that, LVEF is not the best measure. We should be looking at GLS. And in future CMR-based measurements of myocardial fibrosis. Thank you.
Excellent talk, sir. Thank you very much for educating us about aortic stenosis beyond gradients. I mean, all of you will agree with me. At present, everybody is just used to seeing that gradient. Mean gradient less than 40, that means patient does not have severe AS. So my two questions for you, sir, for all the audience, on behalf of all the audience and as well as me, what do you think now should be the standard way to report an aortic valve disease in the 2D echo, apart from gradients? Inclusion of valve area, whatever, I mean, your suggestion.
Yeah.
Number two, sir, that presence of cardiac amyloidosis is very important. When we do these studies and if patient has cardiac amyloidosis, they continue to have diastolic heart failure. So what is the way to evaluate cardiac amyloidosis or suspect cardiac amyloidosis on 2D echo, sir?
So, first question, in every patient with valve disease, not just aortic stenosis, those who are doing echo, this is a message for them, always look at the valve and valve opening. If the valve is not opening well, then low gradient does not mean anything. There is some problem with the valve which we need to identify. So therefore, in every patient with aortic stenosis, look at the valve, how calcified it is, calculate aortic valve area in every patient, calculate stroke volume in every patient. Once we do this routinely, we'll be able to easily pick up all these hemodynamic entities. And when we have doubt, we can then look at further measures like aortic valve calcification, valvular arterial impedance, and so on. That is one. Yeah. Okay. And the second thing about amyloidosis, on echo, we can pick amyloidosis if there is biventricular hypertrophy with biatrial enlargement, there is restrictive mitral inflow pattern, the myocardial architecture is usually altered. We may find thickening of valves, interatrial septum. ECG may not show significant LVH, even though there is LVH on echo, and GLS will show usually apical sparing pattern. So all these will be pointer or red flags towards the possibility of amyloidosis.
Dr. Sanjeev has asked.
Manish, in a moderate AS with normal LV function, if symptomatic, we always look for the secondary factors like uncontrolled hypertension and all other factors, thinking that the symptoms are not because of AS primarily, it is because of combination of factors. But as per your data, like in a GLS, even in the moderate AS with normal LV function, if the GLS is impaired, we should go for an intervention. Is it so?
No, actually, right now we don't have data, randomized data, even for severe aortic stenosis. So you have severe AS, EF is normal, GLS is reduced. If the patient is symptomatic, you will go for intervention, but patient is asymptomatic. There are a lot of studies which have shown that these patients will benefit, but we don't have RCT, therefore this is not a standard recommendation. So in patients with moderate aortic stenosis, who does not have whose EF is normal, but GLS is reduced, I don't think we can recommend intervention at this stage. If there is frank LV systolic dysfunction, then that is one possibility where we might consider, but again, that is also not a current recommendation.
So one more question, sir, and then we can have questions for more. Would you ask your referring cardiologist or the duty doctor to report body surface area on the requisition form? Number one. And number two, would you advise us to do it mandatory for all patients to calculate an indexed aortic valve area or indexed mitral valve area?
Actually, this is a very important point. This is something which we should be practicing for every patient with who comes for echo, because we are reporting chamber dimensions daily. We know that Indians have smaller heart sizes as compared to Western populations. We are using Western guidelines. We are not indexing valve area. We are committing blunders, simply put. So we should be estimating body surface area in every patient and reporting it.
How do you find the dimensionless index in assessment of the severity of AS as compared to gradients?
Compared to gradients, dimensionless index is definitely less flow dependent, and I depend more on that, because you see, once you have, for valve area, you have to multiply LVOT area with dimensionless index. So once you get dimensionless index less than 0.25, You know that if you calculate valve area in patients in Indian setting whose LVOT diameter is usually around 2.2 centimeter, valve area is going to be less than 1. So dimensionless index less than 0.25 automatically indicates that valve area is also reduced. So it is more dependable than gradient, definitely.
And definitely it's more easy to calculate in dimension.
Yes. But we should still report AVA in every patient.
Definitely.
Dr. Manish, what's the role of exercise testing in assessment of the severity?
Yeah, exercise test is indicated in patients who have severe aortic stenosis, who are apparently asymptomatic, who don't have any other classical indication for AVR, like EF is normal and peak velocity is not more than 5, and there we want to make sure that the patient is truly asymptomatic, and second, how his hemodynamics respond to exercise. So if on exercise blood pressure does not increase by 20 millimeters of mercury or actually falls, that is an indication for AVR. But studies have shown that GLS does fairly well as a substitute for the information that we derive from exercise.
How much time will it take for a cardiologist to calculate a GLS if he has to add that to his report?
With current machines, 30 seconds.
Okay, so I think that's a positive point, because sometimes when we are doing this echo, you feel that it might take too much of time. So it's just 30 seconds.
Dr. Bansal, this is Dr. Bhupati.
Yeah.
So the classical meaning, both ACC and ESC have removed the normal flow, low gradient, severe AS. We are not clear what exactly we should do in those patients. I'm not talking about paradoxical, I'm talking about the normal flow gradient. Or there are papers that says that these patients do equally good as compared with moderate aortic stenosis patients. So some authors believe that they should go for surgery. I mean, replacement, either transcatheter or surgical, is a different question. Some authors believe that they should go for medical therapy. So what is your take? How will you go about such patients?
So actually, normal flow, I mean, when I described low gradient AS, I talked about low flow because that is the most common scenario, but roughly 10% patients will have normal flow. So there, first we need to make sure that our measurements are correct. Assuming that all the measurements are correct, the patient has truly normal flow, then there is debate whether they behave more like moderate AS or they have severe AS. Studies have shown that they probably behave more like moderate aortic stenosis. In them, intervention is not indicated. But in these patients also, if you look at other parameters, like if there is significant valvular calcification, if there is myocardial dysfunction, then their prognosis may not be as good. So they will need more closer follow-up, but not intervention right now at present.
So if there are no further questions, I think thank you very much, sir, for that excellent talk. And I think we all in the audience definitely have few take-home message which will help us in changing our practice. Yes, Dr. C.P. Srivastava is there. So welcome, sir.
Yeah,
You have questions?
My question is two extremes. First is just now, Dr. Meena Sahab said that normal LV and very significant gradient means velocity of more than 5 meters and like that. Patient is asymptomatic. Other extreme is what is the lowest EF? You people recommend that you should go for replacement or intervention. Means nowadays intervention, but before it used to be replacement. Okay. And then I'll add my some points to it.
So first, patients who have got very severe AS, like peak velocity more than 5, which means peak gradient more than 100, it is already class 2 indication for intervention. And actually, if you look at the ACC guidelines, they mention that most of the patients who present with severe AS have EF normal EF, asymptomatic. Their median time to intervention or development of symptoms is only 2 years. So even if we wait in a garden variety severe AS, it's going to be only 2 years before the patient undergoes AVR. So there's no point waiting in these patients whose gradient is already above 100, and the guidelines endorse that. The second is, what is the lowest extreme of EF at which we may intervene? So in patients in whom AS is the cause of LV systolic dysfunction, actually there is no lower limit below which we should not intervene. In fact, I did not show because of the paucity of time. Topaz TAVI registry showed that in patients with severe AS, LV systolic dysfunction, even if there is no contractile reserve on dobutamine echo, they do as well as people with contractile reserve after TAVI. Their EF also improves. So in a patient who does not have any other reason for LV systolic dysfunction, we should offer TAVI for every such patient.
Yeah, that is what I wanted to add, that even in our surgical practice, we have operated 15% with isolated AS, no AR, like that. AR is not contributing there, and we had very good experience about it.
And I think, sir, we would agree with your point. Patients with severe AS, severe LV dysfunction, even if they don't have any contractile reserve, they do better with AVR compared to medical therapy. That AVR could be SAVR or that could be TAVR.
Yeah.
That brings another question. Should we even do dobutamine stress echo?
No, I mentioned that role of dobutamine echo is becoming increasingly limited because we know that these patients are going to benefit from TAVR. TAVR has actually changed the whole scenario because of the low initial risk, procedural risk.
Thank you so much.
In fact, if you do dobutamine and it is positive, that gives you some encouragement for some strength. Though, okay, you can say that you'll get benefit.
So that's a very good point. You can do dobutamine stress echo so that the operator is confident that his patient will improve.
Yeah, correct.
Thank you very much, sir. Go ahead.
Thank you very much, sir, for this wonderful scientific talk. May I request all esteemed chairperson to present memento to Dr. Manish Bansal, sir. Please be here, sir. May I request to all esteemed chairperson, sir, please present memento to Dr. Manish Bansal. Thank you very much, sir. Request to all of you, please take your seats. For the next scientific session, I would like to invite Honorable Chairperson on dais, Dr. Gautam Sen, Dr. Shripi Srivastava, Dr. Ramesh Patel, Dr. Sanjay Gandhi, Dr. Ravi Inania, Dr. R.K. Gokhru, and Dr. B.M. Goyal. May I request to all of you, please come on a dais and chair the session.
So the next talk was supposed to be given by Dr. Amit Chaurasia on imaging for TAVI selection, CT scan. For some reason, Dr. Amit has not been able to come. I think there was some last minute emergency. So I'm trying to fill in for that talk, and the reason I'm trying to do it is because CT scan is very important as we all, plan to do our transcatheter valve therapies. Can I start with your due permission, sir? Okay. So what are we looking at when we evaluate a CT scan for patients with severe aortic stenosis? We are looking at the valvular complex, and second is the access route. Before even I proceed further, let me ask a question to my cardiac surgery seniors colleagues. Do you do a CT scan when you are evaluating a patient for AVR? A routine CT scan, sir? Dr. Sanjay Gandhi? Professor Devaguru, sir, routine CT scan for a patient whom you are evaluating for AVR? Sir? So I think that's very important. The reason is, we came across few cases when I was in the US there also, and one or two cases here itself. Our surgical colleague took the patient for AVR. When they opened the sternum, they found that patient had a porcelain aorta, and the sternum was closed and AVR was not done. But I think they all are experts in evaluating a patient without CT scan. And as Professor Devguru also pointed out, if you're evaluating a bicuspid valve, you need to do a CT scan to look at the ascending aorta size and all. So what are we looking at on CT scan when we're evaluating a patient for transcatheter valve? One is valvular complex, second one is the access route. What is the problem with 2D echo? How many in the audience routinely measure aortic annulus when you are referring a patient for AVR? Annulus dimension? And let me tell you, that does not mean anything for a surgeon, because when they open the patient, they will remove the leaflet, put the sizer and size their valve. It just gives some idea about it.
The limitation is, if you look at the echo parasternal long axis view and look at the CT scan annulus, you are measuring a different plane. Probably you are measuring a short axis dimension of the aortic annulus. So there is no correlation between the echo assessment and the CT scan assessment. But multi-slice CT scan is the investigation of choice when we are sizing an aortic valve, because it is highly reproducible compared to the echo. Now, so these are the four comparisons which have been done: echo measurements, multi-slice CT scan mean diameter, multi-slice CT scan area, multi-slice CT scan perimeter. So out of these, perimeter was the most important measurement, which resulted in least paravalvular leak, and the worst was echo-based valve sizing. Now, in the TAVI era, there are two types of valve. One is a balloon expandable, one is a self-expandable valve. All balloon expandable valves, they are sized based on the area, because for a circle, area is a better dimension. For all self-expandable valve, they are sized based on the perimeter, because for a non-circular object, a perimeter is a better dimension. Now, what we are looking at, we are not looking at the aortic annulus, we are looking at the aortic valvular complex. So what does the valvular complex include? It includes the aortic annulus, sinotubular junction, sinus of Valsalva, left ventricular outflow tract, AML, coronary height, and ascending aorta. It's very important, and that's how you can predict whether a patient who is to undergo a TAVI will be low risk for TAVI or high risk for TAVI. This is very important. Whenever we are talking about risk, we are talking about the surgical risk. Nobody is talking about the TAVI risk. Patient is low risk for surgery, high risk for surgery, intermediate risk for surgery. There is a category of patient who are actually low risk for surgery but extremely high risk for TAVI, and that is because distribution of the calcium, bicuspid leaflets, low coronary height. You might send this patient for a paravalvular leak, and you might convert an elective low risk surgery into an emergency high risk surgery. So that's very important, and that's why we need to understand the CT scan. Now, what is the fluoroscopic annulus, or what is the intervention cardiologist annulus? We can't feel the annulus and say this is the annulus. For us, we need to understand the fluoroscopic anatomy. And as we all cardiologists move from coronary to the structural, we should be able to tell on that fluoroscopy screen, this is left atrium, left ventricle, septum, aortic valve, mitral valve. So that's fluoroscopic understanding is so important, and that's why it is advisable or that we should scrub in few of the surgical cases to really understand the anatomy of these valve leaflets, aortic valve and mitral valve. So what is the fluoroscopic annulus? Fluoroscopic annulus is the hypothetical plane where nadir of all three cusps is into a straight line. In the past, we were to start with LAO caudal view, but now this plane can be obtained from the CT angiogram. Majority of time it correlates, but sometimes patient might be lying down in a separate plane on the CT scan table compared to the fluoroscopic table. What else we are looking at? We are looking at aortic annulus, sinus of Valsalva, ascending aorta, LV outflow tract, and coronary ostia height. The way, again, we need to look at the morphology of the aortic valve: tricuspid, bicuspid again, type of bicuspids. So I'm just going to give an example. This could be type 0, type 1, and type 2. There could be a left and right fusion, a right and non-fusion, or a right or left and non-fusion. So imagine you are evaluating a patient with bicuspid aortic valve. Now there is a left and right fusion, and the left main is very low. Now you know from the CT scan that whole valve is going to sit away from the left and right fusion, so coronary will be protected. Another scenario, a patient has non and right fused. Now the left main is say 12, 13, 14 mm above, but the whole valve is going to sit in the left sinus, and that increases the risk of coronary occlusion. So just an idea why it is so important to evaluate what type of valve. Then also again, what is the calcification, what type of raphe is it? Majority of time in bicuspid aortic valves, we cannot fracture this raphe, and it helps us to undersize the aortic valve. These are the different morphologies of the aortic annulus. We all know about it. I'm not going to go into detail. It's not always circular. Then we calculate the short axis and the long axis and the mean diameter. The pre-dilatation balloon is sized based on the short axis. So sometimes I come across a question that patient will have severe AR when you do a pre-dilatation. Now you have a patient with severe AS, cardiogenic shock on ventilator. You want that patient to recover. The only way to recover is you do a balloon aortic valvuloplasty. Now the question comes, the balloon aortic valvuloplasty will cause severe AR. No, if you size your balloon based on the CT scan. Now if the size of the balloon is shorter than the short axis of the annulus, it will never cause severe AR. And that is why we don't see severe AR when we do balloon sizing based on the CT scan. So that's very important. And post dilatation, I'm putting a 29 valve does not mean my balloon is 28. My balloon would be just 25. The post dilatation balloon is sized based on the mean diameter of the aortic annulus or area derived diameter or a perimeter derived diameter. How do we calculate this plane? Multiplanar reformatting. There are multiple software available. I use Osiris. The industry has 3Mensio. 3Mensio is a $50,000 software, which I think not many hospitals can afford it. But Osiris is a cheaper version which helps us to evaluate this annular plane. This we already discussed. We are looking at RVOT, RA, left atrial appendage, left atrium, and the LVOT plane. So this is the diagram of the conduction system and its relation to the aortic annulus. Very important. When the TAVI started with the self-expandable valve, the pacemaker rate was 25 to 30%. With balloon expandable valve, again the pacemaker rate was around 10 to 15%. Gradually what happened, we started understanding that the complete heart block happens if the valve is 5 mm or deeper into the LVOT from the annular plane. And then we started understanding something called length of the membranous septum. If you look at the anatomy, the conduction fibers, they go beneath the membranous septum. So if your membranous septum is 2 mm and you implant the valve at 4 or 5 mm and this patient has right bundle branch block, there's high chances this patient is going to go home with complete heart block. With all valves at present, the pacemaker rate is in single digits, be it self-expandable, balloon expandable valves. And the reason we are able to do it is we are implanting valve higher compared to the previous implantations. And I think our surgical colleagues will also agree to it that the membranous septum, it is below the RCC and NCC. And just below the membranous septum, that is where the conduction fibers exit. Aortomitral continuity, very important. If the aortomitral continuity has a lot of calcium, there's high chances that there can be a problem. There are case reports where perforation of the base of anterior mitral leaflet has happened due to the TAVI valve. What other thing we are looking at on CT scan? The TAVR landing zone. So if you look at this CT scan, heavily calcified left ventricular outflow tract, very important. You need to understand the distribution of calcium. Calcium on the leaflet is good for us. Calcium on the annulus and LVOT is bad for us. So this patient with this much of LVOT calcium, you know up front, this patient is going to have mild to moderate paravalvular leak post-procedure if you are using a first generation valve or maybe a mild paravalvular leak with the latest generation valve which has got skirt on the outside. But then you also know before even entering the cath lab, if my patient has mild paravalvular leak, I will not post-dilate because you will end up with a dead patient and zero paravalvular leak instead of a alive patient and a mild paravalvular leak. Again, an LVOT calcium increases the chance of complete heart block, increases the chance of Garbody defect. You can have an LV to RA shunt. So very important for us to understand the calcium distribution. I'll just take a few more minutes. Sinus of Valsalva diameter, very important. The way a coronary occlusion happens is not due to the TAVI valve. The coronary occlusion happens by displacement of the native leaflet. When you put the valve in, the native leaflet will be lifted up and it needs to go somewhere. If the sinus of Valsalva are shallow, it will occlude the coronary ostia. But if the sinus of Valsalva are wide, the sinuses will fill during diastole and the coronary will keep flowing. So very important, it is not the TAVI valve which is causing coronary occlusion, but it is the native leaflet which is causing coronary occlusion. Few anatomies which we are not discussing here, but sometimes when you are doing, you think that the valve might embolize, then you take different steps or precautions to do these TAVI assessments. Coronary ostia, as I said, there is no absolute number, but coronary height more than 12 mm you are safe. Coronary height less than 10 mm you need to calculate the sinus of Valsalva diameter, the leaflet length and its interaction which is going to happen. The aorto angle, again nowadays majority 95 to 99% of TAVIs can be done by femoral artery, and that's why it is the TF TAVI which is class 1 indication. If you are doing a TAVI in a non-TF approach, you might as well send this patient for surgery. Peripheral vessels, very important. You need to understand the size of the peripheral vessel, the calcification, and the angulation. So when we talk about sheath, 6 French, 7 French, 8 French, 9 French, what are we referring to? We are referring to the internal dimension of the sheath. But what is interacting with the vessel? It is the outer diameter of the sheath. Now, a healthy vessel can be stretched to 1.15 times its diameter. An unhealthy vessel cannot be stretched beyond 1.05 times. Now, if the ratio of the sheath to the vessel, sheath's outer diameter, if it is more than 1.05, there is a high chance of vascular rupture and vascular complication which can happen. Now, another important thing is you need to identify the common femoral artery spot, because the access into the common femoral artery puncture is important if you have to deploy our ProGlide devices. And this is a 3D reconstruction. Thank you very much for your kind attention. Sometimes, there was just one slide which I didn't show. Sometimes these patients have high creatinine. Now, for them, we do a non-contrast CT scan and a 3D TE to assess the aortic annulus. Thank you so much.
Thank you, Ravinder. As usual, very excellent. So, you said might as well send the patient to surgery. So, what is this category now of might as well send to patient?
That's
absolute, and depending on the expertise of an institution where TAVI is still not developed to the extent you're talking about, would you rather get the patient sent to a TAVI center or allow a surgeon to do it?
So that's an excellent question, sir. Out of so many valves which I've done, I'm yet to do a non-TF TAVI. So you do some peripheral angioplasty and try to do it. But answering your question, sir, if you calculate the STS score of a 75-year-old healthy individual, that STS score will be around 2 or 3. That patient is low risk for surgery. But for some reason, let us say his peripheral vessels are just 3 mm or 4 mm. Now you know that you cannot do a TF TAVI. But this patient is low risk for surgery. So you're trying to approach a subclavian, a carotid, a transaortic, that is absolutely no. Because this patient is low risk for surgery. So you send this patient for surgery. But if I have a patient who is a high risk for surgery or prohibitive risk for surgery, in that category of patient only, I would do a non-TF TAVI. Otherwise not.
How comfortable you are with bicuspid valve?
So again, a very good question, sir. Now, I published my data in Indian Heart Journal, sir. 30% of aortic stenosis which we are doing in our country is bicuspid. As I said, bicuspid is very important. We need to do a proper evaluation of ascending aorta, bicuspid, type of raphe, LVOT. Now, a bicuspid, the reason why the bicuspid is more common in India and in Asian, the average age of the cohort of TAVI, of my patient which I published, is 73. The average age of TAVI patients who are undergoing TAVI in Western world is around 78 to 82. Now, if you do TAVI in younger patients, they are likely to have bicuspid aortic stenosis, because bicuspid aortic valve presents at a younger age compared to a tricuspid valve. So, as I said, sir, if my bicuspid is low risk for TAVI, I would do a TAVI. But if my bicuspid is high risk for TAVI, the patient is going to go for surgery. For example, we evaluated a patient. The patient's annulus is 1000. So I know if I do a aortic TAVI in that patient, he's going to have paravalvular leak. So he's going to go undergo a surgery.
Because on table, when we see bicuspid valve, we have to really make a tricky situation. It's a very, with the sutures, because they are never in one plane. The huge cusp is always very deep down. And there we have difficulty in placing the valve most of the time.
So that's the same difficulty we find in our TAVI patients also, sir. The reason in bicuspid is the coaptation is not happening at the annular plane. It is happening slightly above. And that's how the sizing is also different. You undersize the valve. A lot of us thinking goes into a bicuspid valve. So we can have a full day seminar on bicuspid aortic stenosis.
The CT scan has now made a lot of awareness in the sinus of Valsalva, the shallow sinus of Valsalva, deep sinus cusp. Now, does that make a difference about referring patient for TAVI or surgery?
That's again a very good question. Now let us say if I'm putting a valve TAVI patient, my patient is just 63-year-old female. Now patients above 65 has become a class 1 indication as per US FDA if you can do a femoral. Now if I'm seeing a 63-year-old patient, I'm putting a TAVI valve, the sinus of Valsalva is very shallow. I know this patient will need a valve-in-valve after 10 years. Now after 10 years, this patient is only 73. If I put a TAVI valve, now sinus of Valsalva are shallow. If I put another TAVI valve, there's a high chance of coronary occlusion. Because now you're creating a tube graft. But if my patient has a wide sinus of Valsalva, then I know that chances of coronary occlusion are very less. So what we are doing is everybody is calculating STS score, low risk, but nobody is seeing low risk is different from young age. So these are two different category of patients.
Presentation, Dr. Ravinder. What is your experience regarding borderline dilated aorta with bicuspid aortic valve, where you have done TAVI, say for example diameter is 3.5, 3.9, where ascending aortic replacement is not indicated. And if you have done in such cases, what is your follow-up and what is the literature follow-up? Do they require re-operation and how to go about it?
So that's a very good question, sir. Now, if the sinus of Valsalva or the ascending aorta is less than 4, the ascending aorta does not progresses, we would go ahead and do a TAVI. But let us say a category of patient where the patient has bicuspid aortic valve and the ascending aorta is 4.5, or let us say 4.8, 4.9. Now, these patients, if they were to undergo a surgical valve, they would undergo a Bental procedure for sure. But yes, we have done TAVI in such patients. We have done TAVI in ascending aortas as big as 5.2, 5.3, probably they were elderly. But my experience is only of 5 years here. We haven't seen any ascending aorta progression requiring a ascending aorta replacement. Now coming to the literature, what it says is once you replace the aortic valve, the ascending dilatation stops. And the reason is by the jet of the blood flow which was hitting the ascending aorta, that is not there. But if patient has got an inherent aortopathy, something like an Ehlers-Danlos or Marfan syndrome, we would not even like to do a TAVI in those patients until unless patient is inoperable or high risk. Again, that brings to the question, if patient is low risk for surgery, you might as well send for surgery.
Here I have one comment about it, the dilatation. When there is bicuspid valve and ejection jet, it gets the eddy currents and it gives rise to dilatation of the ascending aorta. But once the aorta has gone to 5,
yes,
even the abdominal aorta, irrespective of the eddy current, irrespective of the orifice, it goes on enlarging very fast. So that point I think one should be very careful because the aorta more than 5 is a danger.
I agree with you, sir. In fact, because that's what the Laplace law states. If you are more than 5, it will continue to dilate. The other challenge which can happen when we are doing a TAVI in really dilated ascending aortas, when we go with the device, it takes support of the outer curve. There are reports of ascending aortic dissection on table after deploying the valve, and that is by the catheter which goes across the arch and ascending aorta. Yes.
Anybody from here?
Hi, Ravinder. So, Ravinder, I just wanted to know about your comparison with like our surgeons. Like, if we do a minimally invasive AVR, won't it be a far more feasible option, cheaper for our country? And minimally invasive is, if done in a proper way. What is the comparison like? Hospital stay, cost, and everything like
That's
why
a
not
very
minimally invasive AVR to be promoted as against TAVI, which is much more economically harassing to the patient?
That's a very good question, sir. And first of all, welcome Dr. Ankit Mathur, sir, for the conference. We have Professor Dr. Rajiv Bagreta, sir. Sir, welcome. So that's a very good question. Sir, the question was, why are we not promoting minimally access AVR and why are we promoting TAVI? So that question will be more relevant if our entire country has Ayushman Bharat. And that's when it's a public funded program where you want to save the taxpayers' money and offer one of the best therapies to the patient. The advantage of TAVI versus a minimal access AVR, One is of a cardiopulmonary bypass. Number one. Second one is entire TIV, all the TIVs in the world now are conscious sedation. Third is rehabilitation and early discharge. Western world is talking about same day discharge. So I think that would be the main difference. And if you ask me, is there a head-to-head comparison or trial? I can't remember as of now, but people are also entering into robotic surgical AVR, robotic mitral valve replacement. But I think that debate will always continue. So to answer that question, if my patient is high risk for surgery, and that is because, let us say, intubation, cardiopulmonary bypass machine, renal failure, arrhythmia, stroke, TIV will be far superior. Now, if my patient is high risk for surgery, as I discussed, a dilated ascending, a large annulus, heavily calcified valve, then probably a minimal access AVR would be beneficial.
I think we can go on to the next session.
Thank you so much.
Thank you very much.
Thank you very much, sir. And may I request to all esteemed chairperson, please take your seats to proceed further. Thank you very much, sir. And for the next TAVI case presentation, I would like to invite chairperson on dais, Dr. R.S. Rao, Dr. Ravindra Singh Rao, sir, Dr. Sanjeev Roy, sir, Dr. Ramesh Patel, Dr. Nagendra Bhupati, Dr. Dinesh Chaudhary, Dr. Pavan Ola, and Dr. Rajiv Bagratta. May I request to all of you, please join us on dais. To proceed further, I would like to hand over TAVI case presentation session to Dr. Ravindra Singh Rao.
So I think we will start with TIV case presentations. We can have input from all our audience. We have surgeons as well. We have cardiologists. So our first case will be presented by Dr. Rudradev Pandey. Everybody knows Dr. Rudradev Pandey. Dr. Rudradev Pandey is intervention cardiologist at CK Birla Hospital. Dr. Pandey has immense experience of more than 10 years in the field of intervention cardiology. Over to you, boss.
Thank you, Ravinder. Today I am presenting a case as discussed. Bicuspediotic valve are very difficult case, and this case is presented in our emergency. Brief history: 61-year male patient, known case of diabetic nephropathy. He is severe OSA, COPD, admitted with acute LVF in our emergency, and on echo found to have severe aortic stenosis and ejection fraction 35%. So initially, after discussing regarding further management, he was a businessman by profession. He totally denied for any surgery. So we plan accordingly, because we plan first CT aortogram, then angiography. Followed by angiogram, he was found to have double vessel disease, mid-LAD and RCA was disease. So planned was to perform PTCA to LAD and RCA, followed by TAVI procedure. So these were the parameters, and risk factor STS was 8.2. He was having severe BiPAP, he was smoker also. So basically it was bicuspid aortic valve type 0. And basically other parameters, trace MR problem was AR also there, moderate AR was also there to this patient. Ejection fraction was 35%. So these were the CT parameter that also shows the horizontal aorta was also there. That is also a challenging to normal intervention. Bicuspid aortic valve, these are the parameters. Good thing about this patient is coronary height is good, roughly around 17 mm and 19 mm. Sinus of Valsalva diameter more than 30, and this sinotubular junction is also 32. Aortic size as discussed is 43.7. So this was planned. according to the sizing, problem was that for area of 624 millimeter square, a 30.5 myval is 17% oversize, and for 32 it is 28%. Most of the, if patient is having bicuspid aortic valve, generally for tricuspid it's basically roughly 10 to 15% oversizing maximum we can do. But in this space, because it's basically type 0 and also has AR, we are little bit worried about paravalvular leak and popped off of the valve during dilatation. That's why problem was that either opt for this 30.5 or 32. So after discussing a lot, ultimately we deploy this maximum size 32. These were the femorals, very good. These are the various sizes that are available for my valve. So 14 French Python sheet was used. Issue involved with this case was bicuspid aortic valve, very less calcium to hold the valve. Patient has very mild calcium, so we don't have any area to hold that valve. That's why 32 mm was taken. Moderate AR and horizontal aorta. First PTCA to LAD and RCA was performed. These were the synergy stents were put in LAD and RCA. These were the final results. So after a few days, we performed this TAVI procedure. These were the initial shot. They basically bicuspid aortic valve and moderate AR and horizontal aorta. So all these three are basically challenges for doing any TAVI procedure. In these patients, we counsel regarding the development of complete heart block because we plan to deploy at a lower size as compared most of the bicuspid aortic valve plan to place upper side maximum. So deep routing of this valve was planned and properly explaining the chances of development of complete heart block to the patients. So these were the deployment. So my valve was placed, oversize is 22% because 2 ml was less put in that. So ultimately deep placement 70-30 ratio was the ultimate final deployment. Mostly it's 85% and 15% in bicuspid aortic valve most of the time. So very good deployment. Ultimately, these are the final results. No paravalvular leak to the patient, and patient developed complete heart block as expected. These were the final. So patient developed complete heart block, but that was narrow QRS complex and reverted to normal silence rhythm luckily after 24-hour post-procedure. And one ProGlide and one angioseal was used to close this vascular. And ultimately patient discharged healthy. And on follow-up, echo shows same results. These are the parameters. Mean gradient decreased to 8 mmHg and peak to 13. And ejection fraction is 45. On first follow-up, same results are there. Probably next month he will again come. It's 3 to 4 months post-procedure. Patient is doing fine. So this was the case. That's our difficult case for TAVI. And luckily we got very good results and good follow-up of these patients.
Congratulations, sir. Excellent case and great outcomes. And this is that case which all surgeons were discussing. 61-year-old ascending aorta of 4.3. So if you permit, I can ask a question to our surgeon colleagues. How many of you would operate this patient, sir?
All of us.
Yes. So, yes. So I think that's a very good question. So we have, yes.
Sir, 46 mean gradient. No, sir, mean gradient. Post, this is the post, sir.
So the mean gradient was 40 plus, sir. The only risk factor for surgical AVR, I mean, I don't know, you can comment on that, was sleep apnea and OSA. So how commonly do you deal this problem in your surgical practice if a patient has sleep apnea or severe COPD? If so, how do you modify your surgery in such patients? Is a minimal access AVR would help?
No, the sleep apnea has nothing to do with the type of surgery, because after surgery patient is intubated, and after extubation you have to follow the same protocol which you have been following preoperatively. So that does not make any difference. COPD, yes, we take give vigorous physiotherapy and bronchodilators, and they do come out. Unless they are very severe, they do well. Because nowadays, cardiopulmonary bypass is not a morbidity. We have perfected in that thing. Even 3 hours, 4-hour cardiac pulmonary bypass, we don't see any hematuria there down. And patient wakes up, everything fine after 2 hours and extubate.
Professor Devguru, MICS versus conventional AVR in this case?
63 years old, I prefer to do it conventional, upper mid sternotomy, because we don't prefer doing it in femoral route. We don't prefer retrograde perfusion in an older patient for fear of throwing some embolus. We can do an upper mid sternotomy.
Any questions? So I think great case, sir, and I think very well executed. A bicuspid valve, horizontal aorta, large annulus, moderate paravalvular leak. I think that was great. Is a question from Dr. GL.
Dr. Pandey, you are lucky. That's why you reverted your CHV. Ravindra, I just want to ask how many chances they are putting this permanent pacemaker in such patients?
So the data which I published in Indian Heart Journal, sir, it is 5.6% in my experience. The partner 3 trial, again it is 5%. Evolute R, which is self-expandable, now with cuspal overlap technique, again around 8 to 10%. With my valve, the pacemaker rate is less than 5%. With Portico, again a self-expandable valve, between 10 to 12%. But to answer your question, there is a latest study which came out. If a patient has got right bundle branch block, patient undergoes TAVI, does not develop complete heart block, goes home. The operator is so happy that I've done a TAVI in an RBB and patient did not require a pacemaker. Versus a patient who has RBB, undergoes TAVI, and gets a pacemaker. These two category of patients were followed up till 1 year. Patient who did not require a pacemaker, there were increased sudden death in 1 year. So if I were to have this patient in my practice, I would put a pacemaker and TAVI and send him. I'm happy that he will not require 99% of time, but that 1% of time, if he develops a complete heart block, we might lose him. So now in my practice, if I see a patient with right bundle branch block and severe AS, I tell him your treatment is TAVI and pacemaker.
What about left bundle branch block and AS?
So the problem with left bundle branch block is be very careful if you are doing a TAVI in a patient with severe LV dysfunction, low flow, low gradient, severe AS, and left bundle branch block. This patient might eventually end up requiring a CRTD. What actually happens if a patient's EF is normal, a left bundle branch block, when you put a TAVI, you will widen the QRS. So if your patient has low EF, let us say 35% LBB, you do a TAVI, you widen the QRS, the EF might not improve. And that's how you plan your TAVI, how you select the valve, how high you want to deploy the valve. You make sure that QRS remains the same. But LBB is not associated with complete heart block.
For low flow, low gradient, you have to do the hemodynamics first.
Yes. And a round of applause for Dr. Pandey. Excellent case, sir. Very nicely executed. So the next case presentation is by Dr. Ram Chitlangia from Jeevan Rekha Hospital.
Regarding LBBB, the chances to have regarding the LBBB question, the chances to have a pacemaker requirement at the end of 1 month, 30 days, the recent data is 7%. Natural history of LBBB after post-TAVR says 2/3 of the patients recovers. 1/3 of the patient will have higher QRS. The QRS is more than 160 millisecond. There's different schools of thought. One school of thought clearly says go for pacemaker. We do pacemaker, the QRS goes more than 160 LBBB. Number one. Number two is if the patient is going to have a recovered LBBB, still it is recommended to put an extended Holter monitoring in such patients because 7% of such individuals eventually will need a pacemaker within 30 days, 7%.
How the patient will recover from LBB after putting this valve?
It's only mechanical injuries, sir. It's only mechanical injuries. Some edema happened, it subsides.
So the question is, sir,
LBB which develops post-TAVI. Sir's question was LBB prior.
No, I'm not talking about LVB post-TAVI. Sorry, I mistook the question.
So let me ask a question to our surgical colleagues, sir. What is the pacemaker rate in surgical AVR?
I was just about to tell that is less than 1%.
Professor Devu, Dr. Buddha.
No matter it is heavily calcified.
Dr. Gandhi, Dr. Ankit Mathur. So I think that's very important for us. So go ahead, sir. You were saying something?
My experience, none of my patients so far needed any pacemaker implantation post-AVR.
Even if they have baseline right bundle branch block?
No.
They don't. But we do the AVR in patient whom already there is a pacemaker implantation, and post-operative the same continues.
So I think that's a very important feedback which we got from our surgical seniors. When we are doing a TAVI in our low-risk patients, we optimize TAVI in such a way that patient should go home without a pacemaker.
Ravindra, I want to comment one thing. So that patient was having narrow complex CHB. Okay. So that is most likely due to edema, which is mechanical. But baseline RBB, you can have some baseline EP study. If that conduction system below his disease, most likely you will be requiring pacemaker, because that conduction system disease will be progressing. But that penetrating bundle of his, that might you are landing that TAVI, your valve. So that is most likely due to edema. We are also doing AV and RT ablation. So that sometimes we are having this short duration AV vacuum.
No, in fact.
So 8 to 10 days means that what we are facing while doing EP RFA in AV and RTs, 8 to 10 days, some CSBs progress after 8 to 10 days. But if you are recovering immediately, that less likely 99.9 will not progress if that is narrow complex CHB. But it is, if you are doing simultaneous EP and that HV is prolonged, or you are having baseline RBB, that means with aortic valve, your conduction system below his is already diseased, and that will be progressing.
In fact, that depends on at what level AV node is getting damaged.
Sir,
if it is high injury or edema or whatever it is, it could be, you cannot be sure whether it is edema or if it is a high injury, it will be narrow complex. If it is an injury extending right up to the bifurcation of the bundle, left and right, you will have this wide QRS. So that depends on the level of nothing to do with, you cannot be sure whether it's edema or injury.
So that's
why you have to wait for some time. Hopefully, fortunate enough, if it is edema, it subsides. If it is a permanent injury, you have to go for permanent.
So that is that anatomy matters, that where that penetrating bundle is dividing into branches.
I would like to add, one point here. So the surgical colleagues here are telling the less than 1% of AVR requirement. Unfortunately, the partner 3 data says the low risk patients, the pacemaker requirement between TAVR versus Severity for balloon expanding valve is the same, 9%. The problem, what I feel is the mean age of those category of patients is 75 years. Our category of patients are quite younger. So there was a study that in all TAVR patients, they did Holter monitoring, pre-TAVR itself. They found that 30% of the patients had indications for pacemaker. My humble opinion is, do not blame TAVR valve alone. They are elderly people, they are having disease in the conduction system. I'm not denying that TAVR valve is injuring the conduction system, but they are having a milieu to develop that problem already. It's proven fact, sir.
So I think that's again a very important question. In our practice, we can include 24-hour Holter prior to an AVR, which could be surgery or TAVR, if you are seeing an elderly patient. That will give you an idea that if patient has a sick sinus syndrome, an AV node problem, you might consider pacemaker along with an AVR. So let's move on to the next presentation. I see Nikhil is here. Sorry, Nikhil, you can do the case after presentation after Dr. Ram. So Dr. Ram Chitlangia is head of cardiology and director at Jeevan Rekha Hospital. He is also a very experienced intervention cardiologist and is heading the cardiology program at Jeevan Rekha Super Specialty Hospital. Over to you, sir.
Thank you. Thank you very much for a kind introduction. So we have done 2 cases of TAVR till now. My first case was 67-year-old male who was hypertensive, and he was post-bypass in 2013, a known case of COPD, and he presented with class 3 angina symptoms. CT angio was done basically outside, which showed patent graft, except one blocked RSVG to OM, which was diffusely diseased. And echo showed severe valvular AS. So TAVR was planned for this patient in view of poor surgical candidate and due to lung conditions. This was the pre-op echo, and peak gradient was 67 millimeter of mercury and mean gradient was 37 millimeter of mercury, and valve was tricuspid valve. CT analysis was done, which showed this perimeter derived valve area is 23 millimeter and area derived was 22.3 millimeter. So we chose a balloon expandable my valve, and we chose it around 21% oversizing for my valve for an area of 389 millimeter square. So my valve has different sizes, and it has got some intermediate sizes also, from which we can choose the appropriate size for the patient to avoid the patient processes mismatch. And it has some XL sizes also for the bigger sizes of aorta. So again, the aortic root analysis was performed as per on the multi-slice CT as per usual. And we also assessed the vascular anatomy, and the vessels were good in size. 7 and 8 millimeter of femorals were there without any significant calcification and no tortuosity. This was the baseline aortogram, which showed significant calcification with the valvular AS. We did perform the pre-dilatation with 18 by 14 millimeter mammoth balloon, followed by a 24.5 millimeter my valve was positioned across aortic annulus, and it was deployed. This was the final end result. Without any AR and no paravalvular leak was seen, and patient did well on the follow-up. Until 1 year, I have follow-up, and the patient is doing fine. This was the post-procedure echo findings, and the peak gradient was 6 and mean gradient was 3 millimeter of mercury on the immediate post-procedure echo. The second case was a bicuspid aortic valve in a patient, 79-year-old male patient who was hypertensive, hypothyroid, and benign prostatic hyperplasia. His echo showed severe AS. He already underwent a coronary angioplasty to LCX and RC in 2017, and this time this LED was also significantly diseased, which was stented before TAVR, and after 7 days after stenting, he was taken up for TAVR. This was again the valvular analysis, and the valvular derived area was 23 millimeter, and his femorals were good, and the coronary height as well as the sinus of Valsalva was good in diameter. So we chose a 26 millimeter self-expanding evolute R valve, and pre-balloon dilatation was done with 20 millimeter semi-compliant balloon. Balloon indication was bicuspid aortic valve with severe gradient, aortic valve area less than 0.5, and it was a horizontal aorta, so it was difficult to navigate into the valve. This was the pre-procedure femoral angio and baseline aortogram. Then the valve was again crossed with in a usual manner, and balloon dilatation was done with a 20 millimeter balloon. Followed by 26 millimeter valve was taken into the aorta, and it was little difficult to navigate because of the horizontal aorta. Eventually it was crossed. And valve was opened with the rapid pacing. This is partially deployed valve, and ultimately fully deployed valve with no significant paravalvular leak or aortic regurgitation. This is the final end result. Patient is still doing well at the 1 year follow-up, and valve function is normal with recent echo with normal LV function, and symptomatically is definitely better. Thank you.
Congratulations, sir. Excellent cases. The first one was a post-CABG balloon expandable, and the second was a horizontal tortuous valve. Excellent case. Question, sir?
So, for the benefit of all the other people who are sitting here, any specific reason you took the self-expanding valve in the second case and the balloon expandable in the first case? That's one. And secondly, do you think, because I suppose that the second patient, was he symptomatic?
Yes, he was significant. He was having class 3 angina.
Class 3 angina?
Yes. And both reasons were there. LAD was significantly diseased as well as severe aortic stenosis. So we first treated LAD with the stent, and then TAVR was done.
So on a broader perspective, do we think that with the TAVR coming in, the indications for AVR is changing? I mean, what I'm trying to say is that even the asymptomatic patients are going to get more valve replacement, aortic valve replacements with the coming in of TAVR. So maybe
Ravinder is better able to tell.
So that's a very good question, sir. Let me ask my surgical colleagues again. Why were the surgeons waiting for symptoms to appear when patient already had a severe aortic stenosis before doing an AVR? Professor Devguru, sir? Mike, please.
No,
Can I take that question?
I didn't listen to the question.
So the question is, sir,
I think we're waiting for the patients to be referred from our cardiologist. Very clearly, patients don't walk into cardiac surgery offices.
Yeah.
And unfortunately, on the contrary, patients present way late than they should have presented. Not at the onset of symptoms, but when the symptoms are overwhelming the brim. And that is why we have these, huge subset of patients with severe LV dysfunction.
So the question, so Dr. Buddha rightly pointed. The question is, sir, why were the surgeons waiting for the symptoms to appear when patient already had severe aortic stenosis before doing an AVR?
I don't. I tackle my patient in different way. Because it is very difficult to convince an asymptomatic patient for a major surgery, first thing. And we'll show him that, look, your gradient is 80, peak 80, some mean of 40, 45, 50, like that. And the pressure which is generating in aorta and in your heart, every beat the heart is generating that pressure. And this is one of the cause of sudden death, जो आपने सुनते होगे ना कि बैठे बैठे चले गए. Believe me, they just get convinced and come on the table.
Question.
So to avoid that sudden death, because in those patients, angina is not there, only the one finding is there, the severe gradient, and we all know they can die suddenly. Maybe syncope is one of the first symptom, and they can pop off. So that is how we convince them, and they do get.
But sir, how do we say that they are asymptomatic? Because mostly they limit their physical activity. So nobody is truly asymptomatic most of the time.
So let me frame the question hypothetically. Let's say a patient has a mean gradient of 45. He is actually asymptomatic, walks 5 kilometers every day. LV size is normal. So why was this patient not being offered AVR in the past, and we were always waiting for symptoms to appear? Young patient, let us say again, a young patient. Sir?
Just a late referral to us. We are not the gatekeepers. That is the real reason. If we see, we will suggest.
But sir, all the guidelines always said you only have to refer a symptomatic AVR.
No.
Symptomatic AS.
No. In guideline, there is a definitely peak gradient is one of the important guideline. And another thing, the aortic surgery mortality, when I was a student or lecturer or something like that, used to 5-6% like that. Today, again, it has gone 1%. So looking at the result, we get more encouragement and offer this surgery.
So I think sir has answered that last point. The natural history of an asymptomatic severe aortic stenosis was better than the modified history of a surgical AVR, and that was because of 5% mortality. Now, the natural history of severe asymptomatic aortic stenosis versus the outcomes of a surgical AVR or a TAVR in a properly selected patient makes us to do this therapy at a lesser symptoms compared to what we were doing in the past.
I would like to add one more point here. There are 2 randomized studies. that has been published, one in NEGM, other one in Circulation. They are Recovery and Avatar. Both of them categorically showed that patients who are asymptomatic, first one included very critical aortic stenosis, that is velocity more than 4.5. Second one included velocity more than 4. That is a regular one, severe AS. Clearly showed that at the end of 2 years, the first one was 5 years, the second one was 2 years, there was a mortality benefit. So I will not be surprised if the next coming guidelines increase the class 2A status of asymptomatic to class 1 in the next guidelines. So I think the question is made full stop by this recovery and avatar study published in a couple, last month it was published. So it's answered already.
Any questions? So congratulations, sir, for those 2 cases. Now I would like to invite Dr. Nikhil Chaudhary. Dr. Nikhil Chaudhary is an intervention cardiologist at Narayana Hospital, Jaipur, for his case presentation. Dr. Nikhil has more than 10 years of experience in the field of intervention cardiology. He's a close friend and an excellent person. Nikhil, over to you.
Good evening, everyone, and thank you, Ravinder, for the invite. And so basically, as Ravinder and me discussed, this forum is basically a learning for all of us who are in the beginning of our TAVI programs. And so I'll present my case in such a way so that how I approached it and how a beginner should actually work towards starting a TAVI program. So basically, my case is quite similar to Dr. Rudra's case. It's a bicuspid aortic valve. Who underwent a PCI and a tower. This patient also had severe LV dysfunction. So my patient is a 65-year-old gentleman who was quite obese and a smoker, heavy smoker, known diabetic since the past 14 years. OSA again was present. Since the past 5 years, he was having class 3 dyspnea, and now last 3 months, he started having angina on exertion. His past treatment history, around 3 years back at another center, he was diagnosed with severe calcific aortic stenosis with severe LV dysfunction, and he underwent a balloon aortic valvuloplasty there with a 16 mm balloon. Maybe as a palliative procedure, details were not there with me. But the patient was actually, just after a BAV, he was okay symptom-wise, and so he stopped there and didn't go for any further intervention. His angiogram that time was normal. And this time when he presented to me, he was a short-heighted individual, BMI of 35, quite obese. He was an obvious failure at presentation. Chest showed bilateral crackles. CVS again, ESM, and LVS3. X-ray showed cardiomegaly. ECG showed poor R-wave progression, no right bundle branch block. Echo showed a severe calcific aortic stenosis. Morphology could not be deciphered. Gradients were borderline 59/38, but in presence of severe LV dysfunction, his aortic valve area by continuity was 0.65. Dilated LV, dimension of 60 mm and an ejection fraction of 32%. Importantly, again, aortic root here was dilated. His HbA1c was 10.2, basically showed uncontrolled sugars, creatinine of 1.8, suggestive of nephropathy. So my plan of care here was stepping up the diuretics, add ARNI and dapagliflozin again according to optimum heart failure guidelines. And again, his insulin was stepped up, a nephrology consultation was taken, and thereafter, in view of a relatively middle-aged gentleman and needing definitive therapy, we planned him for an angiogram to assess his coronaries. And this is how his angio looked like. His LAD had a calcific border, 80% stenosis in the mid-LAD, and some proximal plaquing. So here the options here were, firstly again, since the patient was not very elderly, a middle-aged gentleman, an option for a CABG with a surgical aortic valve replacement, and the other option of a PCI with tower was discussed. We had a heart team meeting, Dr. CP is here. So we discussed the case and an STS score of 5.9%. So in view of his obesity, lung and kidney condition, uncontrolled diabetes with severe LV dysfunction, he was deemed high risk, and so then we planned a CT angio to assess his valve morphology and coronaries. So I'm not an expert reader, but I'll just share my understanding of the CT scan. So this patient had a bicuspid aortic valve, which is actually a type 2 bicuspid aortic valve. Ravindra would agree this is quite a rare, very rare type of bicuspid, and tower, again, not many cases have been done. So you can see the calcium on the right side. There was some calcium jutting into the left ventricular outflow tract. So on looking at the CT, his membranous septum was almost negligible. So the concerns here for me were this patient already has a severe LV dysfunction, and I need to select a valve where the chances of conduction disturbance should be less. Probably the need for pacemaker should not arise. So we did a CT analysis, and here again the left coronary height was 11.7 mm. Right coronary height was 19.6 mm, fairly adequate sized coronary heights. Sinus of Valsalva here were quite large, so the chance for coronary occlusion were minimized. So the left sinus was 40 mm, right sinus was 32, and non was 36.7. And then aortic valve calcification was moderate here. So, so we derived the perimeter derived diameter, which was 26 mm, and the area derived diameter was 26 mm again. So basically here, Ravinder has earlier pointed out that when you select a balloon expandable valve, you look for an area derived diameter, and when you select a self-expanding valve, you use the perimeter derived diameter. Anyway, both of them were almost similar. Again, just look at the calcium distribution. His femoral arteries were good sized, around 8.6 mm right side and 9.7 mm left side. This is what the bicuspid aortic valve classification is. And earlier we have seen the type 0 aortic valve, where basically it is almost the real bicuspid aortic valve. And type 1 is when there is one raphe, and which is most commonly the fusion of the left and right cusps. And my patient had a type 2 aortic bicuspid aortic valve, where there was a left-right fusion and a right non-fusion. So here again, this is I think most important. Why Dr. Bagreta also asked this question, that why do we select a why do we select a self-expanding versus a balloon expandable valve? So my patient is a middle-aged gentleman. He already has coronary artery disease. I need to do a PTCA for him. In future, I may need to do another repeat coronary intervention. So I need a valve where I can approach the coronaries easily. Secondly, he's 64, another 10 years down the line, he might need a valve-in-valve. So again, I need to select a valve where the second procedure becomes relatively not too complex. Thirdly, again, he has severe LV dysfunction. I need to avoid a paravalvular leak here. Pacemaker incidence I already discussed. In the self-expanding valve, we know that there is a slightly higher chance for pacemaker requirement. So my pacemaker in an already diseased heart, severe LV dysfunction, might actually worsen the failure, and this patient might become a candidate for a CRT. Again, by balloon expandable valve has shown good results in a bicuspid anatomy, a lot of studies there. My patient did not have too much of annular calcium, so if I do a balloon expandable valve, the risk for annular rupture did not seem too high. And finally, cost considerations. We know that my valve is available at a relatively cheaper rate. So basically did a coronary angioplasty first. So here it was actually quite calcific, and there was a lot of melon seeding. So I did predilation at high pressures, which actually led to perforation in the mid-LAD. Tried balloon tamponade, but did not work, and the perforation kept getting ugly. And of course, when you are planning a TAVI for such a patient, you don't want to lose this patient during a PTCA. So put a Graftmaster 2.8 into 19, a covered stent sealed that, and then there was some proximal lesion, so covered sandwiched that with a Promus Elite 338, and this was the final result after an angioplasty. Then took him for TAVR 6 days after PCI, continued his dual antiplatelet peri procedure. We did the patient TAVR under conscious sedation using the right femoral approach. Basically took the left femoral axis, then parked, this is of 5 French JR in the left common iliac, and did a fluoro-guided puncture. Kept a safety wire, V18 safety wire inside the right femoral artery, and then used a 14 French Python sheath. This was the baseline aortogram. And then basically crossed that with an AL2 and a straight tip termo here. And pre-procedure, the gradients were, so peak gradient was 69, and then we did the pre-dilatation with a 20 mm mammoth balloon. So it was a horizontal aorta, you can see, and even difficulty in crossing with the pre-dilatation balloon. So then we chose a 27.5 mm my valve. Again, Ravinder earlier spoke about undersizing in cases of bicuspid aortic valve, but here we actually wanted to give a good annular diameter to the patient, because he might need another intervention down the line, and we don't want to give him a slightly less result. So this valve was actually 10% oversized, which fits into the criteria which we normally use. This was a crossing of the my valve over the navigator device. So some difficulty which we usually expect because the ascending aorta was dilated. So finally this was the valve crossing. You can appreciate becomes sometimes difficult in the bicuspid anatomy. And this was the final valve positioning. Tried to actually not go too deep inside to avoid that risk for pacemaker implantation. And this was the final result after deployment. No paravalvular leak, and negligible gradients post-procedure. And this was the final result. Final DSA for the femoral anatomy. So finally closed that with 3 proglides actually. And post-procedure shifted back to CCU, minimal inotropes, discharged on day 3, and now 3 months post-procedure, patient is doing well. Actually, he started walking a lot, and his HbA1c is fallen to 6.5. So his echo again has showed improvement, AF of 42, and gradients of mean gradient of 6 millimeter mercury. Thank you everyone for your attention.
Great case, Nikhil, and excellent outcomes with as how any surgeon would get for a low-risk case. So I think we'll move on to the next presentation by Dr. Dipesh. You have a question, so go ahead.
Congratulations, Nikhil.
Thank you, sir.
See, Ravinder, this is a low flow, low gradient case. Here output was less than 32, EF was 32, and the gradient was 38 millimeter mercury. So before doing the revascularization, is there any indication of doing the viability study first? And what is the prognosis post-tower in such patients for improvement of the EF?
That's a very good question, sir, and Dr. Manish Bansal gave an excellent talk. If patient has mean gradient of around 38 with an EF of 35-40%, that means for sure this patient has true severe AS, because you just need another 2 millimeter of mercury to get to that number of 40. But the first talk was echo evaluation beyond gradients. So you calculate aortic valve area, dimensionless index. For your comfort level, you can do a dobutamine stress echo. Now, that was an excellent PCI outcome, but sometimes what I do in my practice, I would just do the aortic valve. Because if you do a very high risk PCI and patient has severe AS and patient develops some coronary complication, patient will have hemodynamic compromise and might not survive. So once you fix the aortic valve, the hemodynamics improve and those patients can tolerate a CAD procedure very well. But then that's my perspective, but excellent outcome. There are a lot of papers which are published of concomitant PCI plus TAVI. Me and Bhupati, we have accumulated 25 data where we have done 25 PCI plus TAVI in the same setting. But sometimes if this patient was elderly, doing TAVI itself would have helped.
Yeah,
so viability, I mean, EF is around 35%. The coronaries are flowing. I would prefer a viability only if it is a totally occluded coronary, not in a flowing coronary. Any questions, sir?
I think these days we are doing viability studies by also MRI, cardiac MRI. That probably validates against the usual viability modalities. So that's reasonably simple also and very fast. So if at all we have some doubt, we can go for viability studies. With these dobutamine stress echoes also can be done, but it's supposedly more cumbersome than cardiac MRI. So yeah.
So I just have one small question for you, Ravinder, that when do you do a DSE? in my case, actually, I was, as you said, I was almost sure that the valve area by continuity was 0.65. I felt it's definitely severe AS. But when do you do a DAC? And secondly, again, a PCI, whether maybe an FFR could have helped, but my patient had recent angina, so I thought maybe the LED is a contributing factor.
I think you did the right thing. That's absolutely correct. But I was just thinking, if this patient was an elderly patient, let us say octogenarian, 80 plus, then I think doing TAVI alone would have helped him compared to a mid-LED. So, but I think you did the right.
And your understanding about coronary intervention in a self-expanding versus a balloon expanding?
It's almost same now. So the way we are doing a self-expandable is we are doing coronary alignment. The only challenge would be a sinus or Valsalva diameter. That should be wide enough. If that is shallow, you might create a tube graft, but it is all same. Thank you so much, Nikhil. We come to the last case presentation. Dr. Dipesh Agarwal. Dr. Dipesh Agarwal is senior intervention cardiologist and professor of cardiology at Mahatma Gandhi Hospital. He has also extensive experience in the field of intervention cardiology. Over to you, sir.
Thank you, Dr. Ravinder, for wonderful introduction, and I thank you for inviting us for this symposium and workshop. So, my case is almost same what they all previous cases were bicuspid aortic valve. And again, this 60-year gentleman come to us with heart failure actually. He had just discomfort off and on. With syncopal attack, he had history of 2 to 3 times a week since 3 years. And he was managed conservatively every time he goes to the hospital, come back with medical management only. And now he has admitted with history of breathlessness and in heart failure. So at the time of presentation, his blood pressure was low, heart rate was 120 and afebrile with bilateral crepitation. He was intubated immediately and managed conservatively for 2 days in our CCU. During workup, he was found to have severe aortic stenosis with the ejection fraction of 20% with global hypokinesia. Gradient was 64 peak and there was concentric LVH at the time of presentation. Cardiac panel was normal. Trop I was marginally raised, it was 0.44, BNP was 975 and his CAG was normal. And that point of time, after 2 days, he was improved slightly and he was advised for possible AVR. But somehow his STS score was high. Dr. Buddhadit Chakravarti was there with me at that point of time and we discussed about this case. So after discussion with the patient and surgeons, it was decided to do a TAVI in this case and this patient was transferred back to us. So this was his CT angiogram. His aorta was porcelain and overall femoral and peripheral vessels were normal in a straight line. So this was his measurement. Aortic annulus was 29.5 mean with perimeter. And area, the sinus of Valsalva diameter was 37.7. Height was okay, and coronary ostia was 18 and 16 millimeter from base. Looking at lower side, his peripheral femoral artery size was normal. Right was around 6.2, and left was 5.6 and 6. So it was decided to do with evolute R valve because his perimeter diameter was 29, annulus 29. And in this case, it was larger diameter of annulus, so we decided to go with the 34 millimeter evolute R valve because it fits into 26 into 30 millimeter diameter. Along with annulus perimeter is 92 in this patient, it fits into 81 to 94 millimeter diameter. So evolute R was implanted in this case. So this is measurement. Aortic valve seems to be a true bicuspid. It is type 0. Probably I'm not sure, but it seems to be type 0 aortic valve. So this is procedure. We started with Sine approached and fluoro-guided puncture through the right femoral artery, and TPI was implanted, and then root angiogram was done with the keeping in pictal catheter in non-coronary sinus, and then it was crossed with the straight tip pteromo wire, and then gradient was measured from peak to peak from aorta as well as LV. Now this was exchange with the confida wire, and before dilatation of aortic root with the balloon, we checked the position and the proper size of the stent in fluoro imaging, whether it is crumbed or not. Then it was dilated with the balloon of pneumat balloon 23 millimeter because annulus diameter was 29, and the size of annulus is 25 actually, and we keep a balloon of 22 in this case, keeping a slightly lower size balloon to avoid the complication. It was, and then The evolute R valve was implanted from right femoral approach. So this is positioning of the valve, keeping just below the aortic root, not too deep. And then it is opened up. Before deploying completely, we took a deep shoot at the root of the aorta, coronary were flowing, and the position of the valve was okay. Not very deep and not too high. Straight line was seen, and finally it was deployed at this point. Post-procedure, it was gradient was 10 at that point of time, not 0. There was no paravalvular leak, and there was no pacemaker implantation required. There was no heart block during procedure, even after procedure. So after procedure, we did a check echocardiogram. We showed no paravalvular or valvular leak. Gradient was 24/14 at the time of just after deployment of the valve. And there was slight TR, and global ejection fraction improved to 30%, 25% at that time. So thank you very much. This was at that point. Patient is 3 years now we have implanted, and he is coming back. Ejection fraction has improved 60% this patient. Initially it was 20. And he's coming in totally asymptomatic, he's fit and fine. So thank you very much for patient.
Congratulations, sir. Great case and excellent outcome. Any questions, Dr. Dinesh?
One question from surgeons, whether you are also getting this 30% cases of bicuspid aortic valve in your the same? Yeah, it is around like 30% only.
So I think that was an excellent case presentation session. Thank you, everybody. Thank you all the presenters, and thank you, chairpersons.
Thank you very much, sir. And may I request to Honorable Chairperson, please present a memento to our.
Yes, sir.
Has there been any discussion about the rest of the patient, a senile patient at the age of 80? Recently, I have been exposed to 2 patients who had severe aortic stenosis and they were operated. But their mental condition and the rest of the body became so poor that in retrospect, in hindsight, people said, was it worth doing aortic management? So is there any now possible guidelines which determine the non-cardiac reasons for not doing surgery or not doing a procedure?
I think that's an excellent question, sir. If my patient is oxygen-dependent COPD, no TAVI, no surgery. If my patient is end-stage ILD, no TAVI, no surgery. If my patient has malignancy, life expectancy less than 2 years, no TAVI, no surgery. If my patient has disabling stroke, bedridden, I'm not going to go do any procedure for him. Patient has got dementia, no procedure is required. But if my patient is octogenarian, nanogenarian, independent in doing all the physical activities as well as mentally intact, then again, it's the TAVI which is treatment of choice. So in Europe, now anybody above age of 75, you do a TAVI. As per ACC AHA guidelines, above 65 years, if it can be done from the femoral artery, provided patient has a tricuspid aortic valve, it is a class 1 indication. So that's a very good point which you pointed out, that we should be sure that we don't do a futile procedure. Thank you.
Thank you very much, sir. May I request to Honorable Chairperson to present the memento to our honorable speakers, Dr. Rudradev Pandey. मैं रिक्वेस्ट करूंगा चेयरपर्सन से प्लीज आप सेंटर में आ जाएं फॉर द मोमेंटो प्रेजेंटेशन. डॉक्टर R.D. Pandey, Dr. Nikhil Chaudhary, may I request to Honorable Chairperson please present memento to Dr. Nikhil Chaudhary from Narayana Hospital, Jaipur. Thank you very much, sir. Dr. Ram Chitlangya from Jeevan Rekha Hospital, Jaipur. Dr. Dipesh Agarwal from Mahatma Gandhi Hospital, Jaipur. Dr. Rudradev Pandey from C.K. Birla Hospital, Jaipur. Dr. Dipesh Agrawal from Mahatma Gandhi Hospital, Jaipur. Thank you very much, sir, and request to all chairperson, please take your seats. For the next scientific session, I would like to invite Honorable Chairperson on dais, Dr. Gautam Sen, Dr. C.P. Srivastava, Dr. Rajkumar Yadav, Dr. Alok Mathur, Dr. Sanjay Gandhi, Dr. Ankit Mathur, Dr. Buddhatitya Chakrabarti. Request to all of you, please come on a dais and chair the session. Once again, may I request Honorable Chairperson, please come on a dais, Dr. Gautam Sen, Dr. C.P. Srivastava, Dr. Rajkumar Yadav, Dr. Alok Mathur, Dr. Sanjay Gandhi, Dr. Ankit Mathur, Dr. Buddhatitya Chakrabarti.
दीपक देखना आगे.
Now, I would like to hand over scientific session to Honorable Chairperson.
Without any delay, Dr. Deva, shall we start?
Yes.
Hello. For the benefit of our cardiology colleagues, I'll just make a quick introduction for Dr. Devaguru. Dr. Devaguru is a professor of cardiac surgery at the All India Institute of Medical Sciences. He's been a prolific surgeon when it comes to valve reconstructions and repairs, which he regularly does in his practice. We all have been blessed to be his students, me, Ankit, Sanjay. And I think he continues to teach us as yet. So we are honored that you made the trip here from New Delhi. It's a big privilege for us to hear you. The stage is all yours. Thank you.
Thank you, Dr. Buddha. Thank you, Dr. Ravinda, for inviting me. Respected chairpersons and dear colleagues. I'll be talking on reconstruction, patient selection, techniques and outcomes. Since I have to deal with 3 valves, I'll try to be brief and try to rush through in some places. As for the tricuspid valve, the main problem was identifying the person who requires the indication rather than the techniques. This was subtly put by De Vega himself. The tricuspid valve dilates mostly anteroposteriorly. So we have to take into 3 things. One is the dilatation of the annulus, second is the displacement of the papillary muscles, and the third is the tethering, which might be very difficult to handle. So far we have been tackling only the annulus. Now of late we have been trying to adjust the papillary muscle displacement also. As for the patient selection, indication is when the simple indication is when the annulus is dilated. As we have already discussed in the previous, we have to index it. If you index it, it comes to 21 millimeter per meter square. If it is more than that, then for Indian patients, it's roughly translates to beyond 35 mm in diameter. Or in arrested heart, which we rarely do, it should be around 7 centimeters. As far as the techniques, 3 techniques are there. To start with, we had the De Vega technique, and we moved to annuloplasty rings now. In between, we had the case annuloplasty bicuspidization, which no longer anybody does. In the institute, we have modified the De Vega technique. So we'll show the short clip of a modified De Vega and the ring replacement and the advancement of the papillary muscle. This is one video in which we had done a modified De Vega. As you can see, there is hardly any coaptation. It's a dilated annulus. As I said, the papillary muscles are displaced. That displacement produces to prolapse of the chordae. So we take and this is for the anterior displacement of the anterior chordae. We take a 4-row suture with a hard felt. Then we find a place a centimeter below at the depth and a fibrous area and place it. Once this is done, already we can see some amount of cooptation started happening compared to where it was absolutely not touching each other. Now we start with the Devega annuloplasty. There's a small modification. We use two sutures. We intercept at the 12 o'clock position. We start at the anteroseptal commissure. We include the anteroseptal commissure, avoiding the membranous area. Then we keep going. Good bites, but not deep enough to injure the RCA. Then we stop at the middle at 12 o'clock. We come back with another row of sutures and put a hard felt again. This modification was done by Dr. Sampath Kumar because there was bowstringing effect in the routine Devega technique. Again, on this side we start at the posteroseptal commissure. We include the commissural area. This is the area which is maximally dilated, posterior leaflet area. So when we tighten also, we try to tighten this suture first. Once these 4 sutures are loaded, then we keep for sizing we use the back of the handle of the LA retractor, which approximately is around 27 St. Jude sizer, mechanical sizer size. So as I said, we try to tie this posterior annulus first because that is the area where it is maximally dilated. Once that is done, we check again. And it's fairly competent. Next is a ring where this is just to show where we avoid the bundle. This is more severe TR. That's the membranous septum area. This is a contour 3D size ring. The difference between the mitral leaflet and the tricuspid is that we measure the anterior and posterior together when we size the leaflet. This is similar to what we do in the VSD closure. On the septal leaflet, we take on the septal leaflet itself to avoid the bundle area. At least the first few sutures. Just at the membranous septum, we leave a gap, which corresponds to the gap in the ring. After this, it's a routine. After this, the sutures will be similar to what we do. Yes, Etibon. What I use is the Aotic 17 mm needle, double arm needle. Here we give one suture, or just at the membranous septum we leave a gap. Then we proceed beyond that. Once we complete that, this is the completed figure. Then in this case also, after we place the ring, I realized there was a leak. Again I had to put that portion I wanted to show. There is a leak again. Again I address that with the same anterior displacement of the anterior papillary muscle, and that took care of the leak which had. So as far as the technique you want to choose, it will be ideal if you can offer a ring for all patients with severe TR, and if cost is an issue, modified Devega is good, at least for a short term duration. Anybody beyond moderate should have ideally a ring. So as for the indication, as I already told you, it is anybody who has got a large annulus beyond 40, or if you index it, it should be 21 millimeters per meter square. Then you should, or any patient who is having a severe TR, you should have a ring or a Devega, ideally ring annuloplasty. The things which can predict residual TR or tethering, LV dysfunction, and of course if you have increased RV pressures, severe PA pressures are high, then it may predict a residual or recurring TR. Coming to the valve repair in aortic, when we started it was not very common, but now it is more and more attractive to do aortic valve repair. Though I don't have videos, I can put across a small pictorial diagrams. This is indications for, this is summarized of the ASA guidelines. Symptomatic patient with AR will require a treatment, or any patient who is asymptomatic with these dimensions, whether there's a decreased LV function or LVED of more than 70 or LV ESD of end systolic diameter more than 50, or all one, or if you index it like we said in the previous talks, we should index it. It should be 25 millimeters per meter square. When we have these conditions, then there is an indication for intervention. As for intervention, this, as you can see in this area, this is a case where when the valve is repairable. Repairable in the sense we should have a near normal leaflets. It should be a central leak. These are the ideal patients where we can attempt a repair. What are the repair options? These are some of the options which are given. The commonest we do is a small triangular resection. The dysfunction is classified similar to what we have in mitral type 1, type 2, type 3, and type 2 is the commonest we handle. When it comes to type 1 is when the annulus is dilated, which is more difficult to handle. It is more often when you are having ascending aortic dilatation, we have a valve sparing surgery. If you are looking at only at the cusp, these are some of the various techniques which are available. One is triangular plication without resection. One is triangular resection Carpenter's technique, or some free edge plication as proposed by in Toronto group. And these are some of the techniques. It's quite possible, though we hesitate to do the repair, it's very rewarding when you're doing. We most often do repair only when it is associated with VSD or RSOV, but with practice we'll be able to repair some of the aortic valves. To summarize, these are the, as I said, these are the classifications similar to what we have in the mitral. These are the things which can offer. As we can see, if it's a type 1, like if it's a perforation which we get in endocarditis, we can have a patch repair. Or if we have a prolapse type 2, which we have to concentrate, that is where we can do a plication, triangular resection, or free margins resuspension. Some pictures I can show. To analyze, like we do analyze the mitral valve with a P1, P2 junction as a reference point, we have a Freighter stitch which is applied on the nodule of artery, and then we assess all the 3 leaflets, which one is prolapsing. Some pictorial figures of this are central margin plication, where you can plicate the central without resection. Then we have this free end suspension. This is by Toronto group. And then we have the paracameral plication, which is the classical trussless repatch which we are used to during our training period. Then this is the subcameral plication of Durance. Among the commonest we do is the triangular resection, whether without resection. We can do this. This is the commonest we do nowadays. And of course, the simplest is when you have an endocarditis, we patch it up. And we can augment all the 3 cuffs if you want to. We can augment all the 3 cuffs also. Is it possible to repair? We have in Professor Sambar's 2 papers presented, one on techniques of repair and one with rheumatic valve repairs, with reasonably good results. So aortic valve repair is possible, and you can start attempting at least when the cusp is good, when the annulus is not too dilated. Of course, the failure rates is when there is a shortage of cusp and there is some calcification which can happen. And the final this thing is the mitral valve. Mitral valve, is most of us know it is repairable if it is a prolapse, or it is type 2. Type 1 is when we have annular dilatation, which often accompanies the other dysfunction, type 2 or a type 3. So we'll concentrate on type 2 only, where these are some of the things available. Of this, 2 things are very easy to do. One is a caudal transfer, if you have a good chordae, especially in rheumatic valve, or the easiest to do is a artificial chordae, 4 PTFE which we can use, which can be used in any type of prolapse, whether it is rheumatic, if it is myxomatous, you can do it. As far as type 3A, that is rheumatic mitral stenosis, is, as we know, OMC is possible, commissurotomy is possible. And as for type B, no longer we only tell about downsizing the annulus, we have to do something more at the papillary muscle level. For short of time, I'll show how to adjust the chordae. This is one video which shows the caudal adjustment. There are several techniques, up to 27 techniques are described in literature. So the easiest is to compare it with the non-prolapsed area and then fix it with a small Liga clip. Then tie the knots on top of it. The other simplest thing is you put a loose knot, keep filling the ventricle, and at that point where the prolapse happens, just short of it you tie. Or you can put a pledget made of pericardium, which doesn't easily slip when you are testing the ventricle, fill the ventricle and adjusting the length. This is the commonest, the simplest is to adjust with a Liga clip. This is how I do. Every 5 millimeters of free edge should have a chordae, so that roughly if there is a prolapse, it will require at least a 2 artificial chordae, 4 PTFE if it is an adult, and 5 PTFE if it's a small child. This is how it is done. You adjust with the Liga clip, and then you can take out the Liga clip once it is adjusted. This is for adjusting. And then there are several papers on the use of artificial chordae, whether it allows for growth in children. It doesn't grow, but the papillary muscle compensate by growing in a pediatric population. This is one where we can show a caudal transfer. This is the second commonest we use, caudal transfer, especially in a rheumatic population where the secondary chordae are stout. This is a secondary chordae. The ideal thing is to pick up a good secondary chordae and try to transfer from A3 to A2 or A1 to A2. Once it is done, we fix it with a 5-proline with a horizontal mattress. And this I do even if I have to put an artificial chordae, I do this if there's a secondary chordae, because this gives an ideal length. Already it is pre-measured. On top of this, you can. This is a patient who had a pseudo prolapse, so there was hardly any PML. So we augment. This is, if you augment the posterior leaflet, the chance of repairing in a mixed lesion is higher. One point I wanted to tell is you have to incise from commissure to commissure entirely, and when you place the pericardium, you try to put a rectangular pericardium and not a crescent shaped, because like this. Because if you put a crescent shape where the anterior is lesser than the posterior, then we'll have a diastolic gradient post-op. When you use a large pericardium like a triangular, there is hardly any diastolic gradient post-op. And this child being small, we used a pericardial felt as a posterior annuloplasty. One more video is there on posterior prolapse, which is the simplest of all to do. We have to, if possible, resect and address it. I think we are already beyond time. As for the we have 2-3 papers on rheumatic population repairs by Dr. Sampath with excellent results. And the only problem is to develop attitude to reconstruction, and of course you should be prepared for a resurgery. And this is an excellent book on reconstructive valve surgery by Carpentier Adams. So thank you.
Thank you very much, Dr. Guru, for excellent presentation and a big chapter in nutshell, and you have shown all 3 valve repair. My question is that sometimes you do get the tricuspid valve very thick, rolled in. And AML is also thick and rolled in, PML is also thick and rolled in.
How do you tackle that?
In tricuspid, you're telling.
Tricuspid.
If it is, as I said, if the tethering is too much on the septal leaflet, one option is to augment the anterior leaflet, but most often we end up replacing, especially if you have a gradient across the tricuspid valve, and if the leaflets are rolled out, it's better to replace than give a repair which is not good.
Yeah, in my experience, I have tackled this problem. About half a dozen valve I have done, and I don't want to replace it. Means that is always surgeon's attitude towards that not to replace the tricuspid valve. One procedure, what Dr. Sampath Kumar also used to do, but I am practicing that. I do the thinning of the valve, and take out the muck out of that, and it becomes such a transparent valve, and
Cuspal
it
thinning.
works very well. It becomes mobile, and it avoids the
replacement.
Things.
Cuspal thinning we do in the mitral.
No, in tricuspid I do in tricuspid most of and it does work. And really, we are afraid that we might puncture the leaflet, but it does not happen. If you are in the right plane, slowly it comes out. It takes time. Repair procedure always takes a lot of time there, but it works very well. Just for the audience to.
Thank you, Deva. Thank you. You are an international expert now on repair. We know that. I'm really surprised that you did not mention pericardial augmentation of the ATL for severe. It's not a.
We do ATL. We augment. That's what I told, sir. Augmentation of the anterior leaflet is possible.
Right.
In mitral, we only augment the posterior leaflet. For tricuspid, you can augment the anterior leaflet. Especially in children, we keep doing it most often.
So my next question is, are you still repairing the class 3B types of valves, carpetier class 3B? Are you still attempting to repair rheumatic mixed lesions? Because I was part of that study published, the 800 cases from AIMS, Professor Sampath published that. And our results were really not up to the mark with mixed lesions. So what has changed over the last 20 years at AIMS?
One thing is we try to use a ring. Second thing is if it is a child, we'll go all out to repair. We at least buy time to have a good valve later. That's the only thing we feel.
And the results are still wanting for a mixed lesions?
Yes. It's an ongoing process, so it will.
And the second question is why don't we augment the AML? I mean, at times I feel like, traditionally we have been just augmenting the PML and shifting the margin of closure a little anterior.
The problem with augmenting the AML, the main idea is to have a more tissue so that we can put a ring. But by augmenting the AML, the size of the ring cannot be altered. So when you size, it will be same whether you augment or not augment the valve. So the very idea of having a rigid ring in a rheumatic population, which helps in long term, will not be able to achieve.
Now that they are trying to put through the groin most of the valves, putting in a ring to repair tricuspid valves should become mandatory. Looking at the future, this ring will be a good support for any valve to be fitted in. The biggest problem about prosthetic valves and tricuspid and mitral valve positions through the, as we do in TAVI, is they do not have any
annulus,
strong to stick onto without damaging something. Now here in the tricuspid position, we are also worried about the bundle. But if you have a ring, in the future, the patient and the cardiologist may thank you. Is that right or wrong?
Dr. Ravinder will be able to answer better.
I think so. So in standard practice outside India and Western data, to augment every tricuspid repair with a ring, flexible or rigid. D Vegas is completely out of fashion. And it's not just keeping future in mind. The hope is that you won't need another procedure in future if you augment it well enough.
Is that right?
Correct.
Is it a hope or is it a fact?
No, it is a fact. I mean, there is data which is at least 15 years standing, that if you have repaired it with a ring, you don't need a second procedure on that.
Okay, that's part of my
question is answered, but they don't want to help you, Ravinder.
So transcatheter tricuspid valve therapies.
Once you have a ring, yeah, the question was once we have a ring in the mitral position or the tricuspid, will it make it easier for a transcatheter procedure later?
Yes. So for a tricuspid valve, it is standard we do a valve in ring. But the mitral valve, when we do a valve in ring, the anterior mitral leaflet goes into the LVOT and can cause an LVOT obstruction on table. So what we do a certain calculation called neo-LVOT area. So we have done valve in ring. We would hypothetically put the valve and we would see what is the residual LVOT area. Now, if that LVOT area is less than 200 millimeters square, that patient is high risk for an LVOT obstruction during the valve in ring procedure. What we do for them is we would split that AML. It's called lampoon procedure. It's an electrocautery. We would split that AML by doing an electrocautery and put the valve in ring. Or sometimes we do an alcohol septal ablation to widen the LVOT. So this is a challenge in a valve and ring in mitral position, but valve and tricuspid is standard.
And again, just to augment on what Ravinder said, the specific conditions where you would do that is severe MAC, where an open surgery probably would be a problem with a very high risk of stroke. So in those cases, nowadays, there is a transatrial transcatheter modality, wherein through a very minimally invasive approach, you can excise the AML, and you can deploy the valve with anchoring it, the TAVR valve, anchoring it in the mitral position.
In fact, when we do the mitral valve replacement with total preservation of the apparatus, this, what you are telling that you split the valve, that is mandatory actually. Because if we don't tackle those stud chordae onto the left side, that will produce the LVOT obstruction. So, though it is known as total preservation, but we have to sacrifice few chordae which will not interfere with the disc movement plus LVOT obstruction, because that directly comes against that LVOT.
And
so
that's why I'll show that case. That's why a mitral valve in valve is easier, because surgeon has already split the AML.
Yes.
But in valve in ring, AML is still intact, so we have to be very careful when we do a valve in ring.
Yes.
Thank you.
Any questions from the audience?
So what about this posterior Teflon collar annuloplasty? We were part of the big program. So are we still pursuing that over there?
We are not pursuing now. In children, we use a pericardium because redo, it makes it quite fibrous.
But that was a handy procedure if we are not very experienced with the rings, and ring is an expensive thing. So putting up a Teflon on the posterior PML
that is that. Now we have
like
got bands, ready-made bands are available.
So I can't talk too much about it. It's still in publication, but for ischemic MR in adults, just a Teflon annuloplasty seems to work so well, in my practice at least, that it's a study of 29 patients only. We don't get too many and we don't tackle. But 28 out of 29, the only procedure done was a posterior Teflon annuloplasty, which we used to do at AIMS. And so it works really well for this subgroup at least.
First you graft them and then go back again and do, or?
No, at the same setting.
At the setting.
Yeah, you graft them and you do just an annuloplasty.
If you graft them, you are all off-pump people. If you graft them.
not me, man. I love the pump.
If you come off and see.
You're right, sir. During off-pump CABG, after we have done grafting, we analyze the MR or NICO, and we see at least more than 40-50% of the time MR gets reduced, and it doesn't require any procedure.
Dr. Deva? I think that's a very fallacious way of assessing mitral regurgitation on table. I never see the MR improving immediately. I don't understand how it would.
Dr. Deva sir, part of your question, part of Ankit's comment that Teflon heartfelt ring, in our setting there in AIMS Jodhpur, we are using almost 50% of cases with mitral repair where the mixed lesion is, where we know that it's going to be in a second surgery, for sure in next 7 or 8 years time. We are using still Teflon heartfelt ring. And I am still using, nowadays, I'm extended it to the tricuspid valve also. I taken a tricuspid valve sizer, ring sizer, and shape according to that ring, and use as a C ring for the tricuspid valve. So that's also is and use a ring kind of suture only on the tricuspid. So it is better than the Devega, but it is not probably. And I seen a good example of using vein in pediatric kid as in a bend. That's kind of wonderful to see. Thank you.
So even the bicuspidization works sometimes. I've done it in a couple of patients where the lateral leaflet, there only I placated it. It was a huge annulus and it worked beautifully for me.
Just talking about posterior annuloplasty, I'll just make a comment that there's a study published by the Mayo Clinic as way back as 2009, wherein they had 2,700 patients of various forms of MR. And standard practice in Mayo Clinic is to use a 63 mm or a 30 millimeter ring. Probably Dr. Alok would have seen it in practice too. And whether it be degenerative MRs or ischemic MRs, just posterior annuloplasty using a 30 millimeter, that's standard irrespective of the annulus, is standard practice at Mayo Clinic. It seems to work fine for them.
Any question from the audience? I think.
So if
Thank you very much, sir. May I request to Honorable Chairperson, please present memento to our dynamic speaker, Dr. V. Devguru. Request to all of you, please. May I request to all chairpersons, please join us. Thank you very much, sir. Request to all of you, please take your seats. For the next scientific session, I would like to invite once again Dr. Gautam Sen, Dr. C.P. Srivastava, Dr. Rajiv Bagratta, Dr. Alok Mathur, Dr. Sanjeev Devgara, Dr. Anil Sharma, Dr. Saurabh Sharma, and Dr. Alok Sharma. May I request to all of you, please come on a dais and chair the session. Now, I would like to hand over scientific session to Honorable Chairperson.
Buddhaditya requires no introduction. He's been there right from the beginning, and it will be interesting to look forward to what he's going to present.
Very good evening. Dr. Saurabh? Dr. Saurabh was in the audience. If somebody would please contact him. I see Dr. Sunil Kaushal here. Sir, would you be kind enough to grace the stage and also chair one of these sessions? So thank you. There are no ladies in the audience. Oh, ma'am is there. So ladies and gentlemen, thank you for this great evening. I think it's an honor and a privilege for this opportunity. It's also one of those rare occasions when I get to present our work amongst a discerning crowd. Most of times it's CMEs where there are a lot of physicians. So it's a very, very pleasant change, and I'm really looking forward to this. I'm going to keep the format of this presentation very, very simple. The idea is to stimulate a discussion. I'm going to showcase 3 cases here which we have operated in recent times. And at the end of each case, and I'm going to be very brief about these cases so that the onus is more on the discussion part. At the end of each case, I'm going to have a question. And then that question, we'll take at the end of all the 3 questions, I'll have a slide where we'll have all the 3 questions portrayed together. And then we can start a discussion taking one at a time. For the discussion, I would request Dr. Alok Mathur to please help moderate the discussion so that it veers in the right direction in benefit of the scarcity of time we have. So the first case we have is a 54-year-old lawyer who presented to us from another city. Class 3 symptoms of angina and shortness of breath. Investigated at AIIMS Bhopal actually, showed to have on CAG left main 90% and triple vessel disease, almost complete occlusion of all the three coronaries, and severe mitral regurgitation. I'm going to focus on the mitral regurgitation here. So as you see very classically, he had an A2 prolapse, an AML prolapse you can see, and a retracted classical posterior mitral leaflet as you would expect in ischemic condition. He had severe mitral regurg. Thanks to our cardiology department, we have some brilliant images in 3D echo. You can very nicely see the prolapsing anterior mitral leaflet and the retracted posterior mitral leaflet and central severe jet of mitral regurgitation. So standard surgery, 4 grafts, lima, rima, radial and vein, and a mitral valve repair. We put an artificial neocord to the A2. We also trimmed some of the minor chordae of the posterior mitral leaflet, and we downsized with one size down with a Physio 2 ring, Edwards Physio 2 ring. That's my go-to ring for ischemic MRs. And the on-table repair with a saline test. I know the video is not great. We don't have a head camera, so we are trying to do the best we could with whatever from the head end of the patient. I think you can appreciate the fact that there wasn't any saline leak on table. And we came off fairly comfortably. The echo, as you see, you would appreciate that there is good coaptation. The anterior leaflet seems to be coapting beautifully with the posterior, it's pushed up. And the patient had a fairly uneventful recovery and went home. So the questions based on this is, from what I believe, and I know all of us subscribe to that ischemic mitral regurgitation is more of a problem of the ventricle than it is of the mitral valve. So is downsizing the mitral annulus enough? If yes, then what is your philosophy of downsizing? By how much do you downsize it? There are some schools of thought who would go 2 sizes down. Somebody would, downsize it to the same size as that of the anterior mitral leaflet. And then what is the prosthetic ring of choice? I'd be very keen to hear what you gentlemen have to say in your experience. If you haven't seen this documentary on Netflix, please do. It's highly recommended. I've seen it thrice. It's amazing, it's thrilling, it's inspiring. And I think it's the very philosophy of mountaineering, You are about to climb onto a hostile environment. As well prepared as you are, there's surprises around the corner. There's nothing that can prepare you for what's up there. And you've got to innovate, you've got to reinvent yourself, and you've got to pray hard. I think the next case which I'm going to present symbolizes all of that at one go. So this was a 33-year-old lady who presented to us with acute congestive heart failure. She's had multiple interventions on her mitral valve, and way back in 2014, at the age of 27, she got implanted with a bioprosthetic valve in a mitral position with the hope that she would go into the family's way. Unfortunately, that did not happen. But what did happen was that one of the leaflets of the prosthetic mitral valve gave away, resulting in florid torrential acute MR and florid pulmonary edema. And the patient was brought to us with SATs in the 80s, hypotension, oliguria. And lo and behold, when we did the echo, and I'll share the images with you here, the patient in his previous echo had a small aortic root. You can appreciate the small aortic root here, and some degree of moderate aortic stenosis, which had now progressed to severe aortic stenosis. And of course, you can very well visualize, it's a brilliant echo image here, you can very well visualize the mitral prosthesis here. So she had torrential MR and she had severe TR. So the patient all in all had severe mitral regurg, she had severe aortic regurg with AS, and she had severe tricuspid regurg. We tried optimizing the patient as best as we could medically, but of course you understand that under the given circumstances there wasn't much that we could do. This was the preoperative CT scan, and of course this was done in the background of COVID, so we always got HRCTs done for the patients, and you could see that the lung condition wasn't really optimal for surgery, but nevertheless we tried to go ahead and dive deep in. The reduced sternotomy went uneventful after dissection. I chose to go the transseptal route to address the mitral valve. And when I was digging to get the old prosthesis out, the pledgets which had buried into the aortomitral curtain, as I got them loose, I could see that the aortomitral curtain was barely there. I mean, it was completely frayed, not good enough to hold the anterior mitral sutures at all. And because the aortic valve you saw was 16 millimeters measured on echo, and the plan originally was to do an aortic root enlargement, we went the trans-aortic route, excised the valve, and then we used a bovine pericardium to augment the aortomitral curtain and extend that right into the left ventricular outflow tract and brought it out into the aortic root. We went through the aortic valve and put the anterior mitral sutures for the prosthesis valve. We went back, we put the posterior mitral sutures and sat at 27 mitral St. Jude. Went back to the aortic, we could put in an implant at 21 size St. Jude's. We augmented the aortic root. We also did a tricuspid annuloplasty. The images aren't great, of course, but you see that I hope you can appreciate the augmentation of the aortic root and the pericardial patch. You can see this pericardial patch here, which was brought out, which was used from the aortomitral curtain to augment the aortic root. And then there's a defect left over the left atrium. We used a second autologous pericardial patch to close that. And finally, at the end of this procedure, if I have not made myself very clear, there's this beautiful paper by my friend and colleague from Mayo Clinic, Sameh Saeed, wherein all these illustrations about this procedure has been beautifully done. I'd recommend at leisure, please go through that and it will give you a fair idea as to how this procedure is being done. And at the end of all this, the heart looked beautiful, it was ejecting well, the LV, which was 40-45%, looked fairly robust, but there was bleed in the endotracheal tube. And the SATs started dipping to the 80s, 70s, and 80s, and we went back and forth from bypass, hoping that things would improve, but they weren't. So we decided to electively put this patient on a VA ECMO. With her chest open, we shifted her to the ICU, and we tried to correct the coagulopathy and warm the patient up as best as we could. She was kept on the ventilator, she was kept on the VA ECMO, for almost more than 24 hours. Luckily, with clearing the coagulopathy, the endotracheal bleed stopped, the airway pressures improved. After 24 hours, we were back in the OR trying to wean her off the ECMO, which we luckily did. And then thanks to the Almighty, we could come off ECMO, close her chest, move her back to the ICU, and within 24 hours, she was extubated. She had a very uneventful recovery for the rest of her course, and on 8th day was home. She's been on follow-up with us for 6 months. The gradients are extremely low, and she's doing very well. That's not a great image, I know, but if you can appreciate the bulge in the aortic position and the leaflet there, and the mitral position, the mitral prosthesis there. So we had a 21 aortic, 27 mitral, and a 30 millimeter ring in the tricuspid with no TR. Which brings us to the second question, valve replacement in the childbearing population or youth who are into active lifestyle. What would be your decision? What would be your choice of prosthesis? So if you go by the ESC guidelines, class 1 indication, women of childbearing age, bioprosthetic valves. But in our context of, reoperations are rare, the economic constraints, I would be very keen to know what's your general experience, what would you advocate for your patient? And then coming to the last case, it was a case where we had to swim against the tide for some reasons. A 68-year-old male who had developed COVID, off and on steroids for 3 months, developed black fungus or mucormycosis, underwent FES, had a history of palpitations but nothing very significant, suddenly felt lightheaded, collapsed, underwent CPR in a private hospital somewhere outside, got intubated, heavy inotropes, almost neuropathy of 20, oliguric, renal shutdown, shifted to us emergently on a ventilator with all these conditions. He was on chronic steroids, ongoing antifungals, and then at the outside center, the primary echo was suspected a dissection, but when we looked at the echo here, we did see a very dilated aortic root, a tricuspid aortic valve, but then something more interesting. So I think I have to give a lot of credit to our echocardiographer for these images. As you see, there was severe AR and some evidence of vegetation on the leaflets and probably a perforated leaflet. Of course, because there was a root dilatation, we decided to go for a CTA in spite of the oliguria and the acute renal shutdown, and this was what we found. So not a case where every surgeon wants to dive into, but we dove right in. The aorta was dilated as expected. Look at the pulmonary artery, equally dilated. And this was what we found. There was a perforation in the leaflet. It was a tri-leaflet valve, and there was all this mush where the leaflets should have been. Luckily for us, after we debrided all this and exposed the root, we had a clear view. I decided to go with a bioprosthetic. It's one of my favorite prostheses. I know a lot of people don't use it or advocate it, but I have used a lot of it, seen a lot of being used at Mayo Clinic, and I'm a big fan. There's this porcine Medtronic freestyle aortic root. It's a great biological prosthesis. So we used that to replace the root, which is very standard operation, just like you do a Bentol with a biological valve. And then we also did the hemiarch in this patient. And I think res ipsa loquitur, that video will tell you how everything went. So of course the patient had an uneventful recovery, got extubated, went home, and is doing great. So that brings us to question number 3. In the setting of infective endocarditis, does the nature of prosthesis really matter? I know we have discussed this ad nauseum. When it comes to the mitral or the tricuspid valve, these valves can be more forgiving. I myself can show you this case of infective endocarditis in a 35-year-old drug abuser from one of the states of Rajasthan. And we debrided the entire tricuspid apparatus, and we reconstituted this valve using autologous pericardium. And we did caudal transfer, we put neocorda, and of course this repair was augmented with a ring. But you see there, we used complete autologous stuff, and that was a good repair we had. The patient's on follow-up with us for about 5 years now, seems to be doing well with trivial tricuspid regurg. So, but when it comes to the aorta prosthesis, aorta is less forgiving, so I'd be very keen to know what are your thoughts, what are your views on prosthesis in infective endocarditis, especially in the aortic position. Thank you very much for your kind patience, and I will switch back to the questions, and I'd request Dr. Alok Mathur to start the proceedings. Can we have the slide, please, back? Yeah, can we have this on the screen now while we...
Thank you, Dr. Buddhadutta. That was, those are tough cases, and I must congratulate you. It's become a showcase of your efforts, and really great. Most of us would have shied away from doing patient 2 or 3. But let me start with Dr. Srivastav, about his ring of choice in mitral, if he does any.
So ischemic mitral regurg, how do you approach it? What do you do? What do you do in a moderate MR case, for example? Would you address it? Would you not? How do you decide?
I divide these cases in 3 groups. When there is a coronary, mild, nothing to do. Moderate, watch. Severe, I don't go for repair. I just replace it, because I don't want to fiddle around. I am not an expert of the repair, so just 30-minute cross clamp, do the beating heart surgery, do the bypass 4, 5, 6, whatever is needed. They tolerate very well. Just keep the aortic cannula on, and the moment they are unstable, you go on bypass. And I must have done more than a dozen replacements now, touch wood, without any mortality. And you are at the end of it, you are giving a competent valve, and in moderate, we assess on the table, and our experience is, and in fact I have given one thesis to one of my DNV candidate, and what we are observing, that moderate mitral regurgitation comes down by 1 degree after revascularization. If it is inferior, it does give rise to the results. I am still awaiting. So this is my policy, because I have not been doing repair since beginning. I don't want to try any experiment at this time.
That's a very interesting observation. Can I? Oh, sorry.
Sure.
Please.
I mean, that is the crux of all literatures and meta-analysis ever. whatever you can do safely in the shortest clamp time is in the interest of the patient. If you are well versed with repairs, go ahead repair it. But if you are not, I think Dr. Srivastava very well point. 30 minutes of clamp time, you replace the valve. It works very well.
Even in
I
somebody.
would like to hear what they have to say on this.
I just had an interesting observation. I mean,
Moderate cases, you just put the mitral ring, that decreases from moderate to mild.
Bypass, it does. We are not putting any ring. We are just keeping that group separate, mild nothing. So in fact, the results are means the study is going on, and let us see what finally outcome comes out. But
can we have the
those
slide
patients,
up?
those patients are symptomatically quite well.
Yeah, the question slide.
Yeah.
Oh,
So, from my understanding, why does ischemic MR occur? I mean, ischemic MR occurs because the infralateral or the inferior wall gets infarcted. There is displacement or infarction of the posterior papillary muscles. There is retraction of the posterior mitral leaflet because the alignment of the papillary muscle and the chorda are disarrayed because of the ischemia. They are tethered or pulled away. And that causes retraction of the PML, and that is what causes, and over a period of time, annular dilatation, of course. So I am failed to understand that how does revascularization immediately help the mitral regurg to diminish?
In fact, it need not to be ischemic. Sometimes what we see, recently I operated one lady who had CAVG done about 5-6 years back. And now she came with a blocked venous graft, functioning memory, which was put to diagonal LED sequential, and sequential vein graft, and those two, that graft had been blocked completely, and severe MR. So did the beating heart bypass on the OM and posterior. When I opened the valve, it was not ischemic at all, it was the myxomatous valve. Myxomatous valve can occur anytime, and just replaced it and they came out.
Didn't it get picked on the echocardiography before?
No, they did say some myxomatous valve.
So let's stay focused on the question. If you do decide to repair, what is your, how much would you
I just
charge?
want to interfere, sir.
Yeah.
See, the primary pathology in ischemic MR is, you rightly said that interpapillary distance increases and the restriction of the posterior mitral leaflet. Only doing the downsizing annuloplasty doesn't correct the whole pathology.
I agree completely.
If you
That's
do,
why this question is up there.
If you do the papillary muscle approximation, the repair is going to last longer.
Exactly.
But if you don't add this, so I do isolated mitral valve replacement where severe MR is there with associated coronary artery disease.
So there's a wonderful paper by Mark Gilinov, as way back in 2009, wherein he has operated 1,400 patients. And the data out there is that if the LVEF is less than 35%, and if the LV end diastolic dimension is more than 62, or if there is basal akinesia, do not try and repair these valves with a ring.
Sir, so one-time operation of mitral valve replacement with the tissue valve is better than doing isolated annuloplasty.
Anybody else? If you are...
Yeah, I mean, that's what the teaching, and that is why my paper is getting a lot of attention. Because theoretically what you are saying is perfect, but the observation is that even with a felt posterior annuloplasty, the long-term mitral regurgitation is behaving very well. So claiming that we understand the disease fully is a sort of an understatement. I think there are a lot of aspects of ischemic MR that we still don't understand properly in the functioning. And it is working. It is really working very well, just posterior annuloplasty. And theoretically, you are right, it should not function because there is so much that has gone wrong with the valve. But maybe so much is not needed for a competent valve. You want a perfect valve, but maybe competence can be achieved with a semi-perfect valve.
I have a comment here. What I do, I have a little experience of ischemic valve, that is in 17 cases, which while I was in Fortis, I did. Now in institute, I didn't get a chance to operate an ischemic valve. What we do is, if LV wall thickness is preserved then we try to do a repair because CABG is going to help that guy. And probably ischemia will comes back, reverted, and that LV valve will work, and for 2-3 years that valve is supported. But later on we find out that just doing a valve ring is not enough. So after 2 or 3 cases, I started doing more, because then I realized that posterior leaflet is still not working so well. So we have started doing a secondary cord cutting in the posterior leaflet, also added that thing.
Unfortunately, that doesn't work very well too. There's data out there.
Yes. And then we realized another subset of the 7 cases which we have done is that anterior wall is also LAD territory. It's a scar there. So what we have done, all in those 7 cases, in beating heart, we plicated scarred LV wall by multiple plagiated sutures, and their MR just disappeared. They didn't require any mitral repair as such. No chamber opening was there. So 17 cases of repair with the ring, and 7 cases of those cases where the ischemic scar.
And what ring do you use incidentally, if you do use?
That time Edwards ring was available for the tricuspid valve, mitral valve, ischemic mitral valve. Now
is it a complete ring or a partial ring?
It's a complete ring. It's complete ring. Always complete ring.
So how big an annulus is good enough? I think we should not stray from the discussion. This is going into a replacement versus repair discussion, which has been going on for 30 years. So if you do decide to repair, what is your annulus criteria?
Some advocate standard 28 ring for all patients, whatever the annulus. For ischemic MR, some advise standard 28 ring for all cases of ischemic MR.
What do you do?
We use a downsizing, and if possible, like simply we release the P2, P3 area. Sometimes we try to augment the PML if it works out. We were using IMR ring, which is out of market now.
I think we should move to the second question. It's a lot of things.
Initially, I also face these sort of patients who are having coronary artery disease, that is ischemic MR. Initially, for mild, moderate, severe, we don't used to touch the valve, but in follow-up, I found that a lot of patients were having NYHA class of 3. And now, year or so now, I have started doing the posterior mitral leaflet Teflon annuloplasty, partial annuloplasty from commissure to commissure. And I take half the size of the 27 valve, that is what I have learned from Dr. Alok Mathur. 2 cases I have operated till date. They are doing excellently fine, and third I'll be operating tomorrow.
Yeah, all right. So moving to the second question, if you are replacing, and I want to add before this discussion, and let's keep it a short discussion. I think the teratogenic effects of acetrom are highly overrated. I think all of us in our experience have seen pregnancies reach a very positive conclusion with acetrom. None of our patients stop acetrom in the first trimester because it's not even diagnosed. And so I'll invite just 2 comments, one from Sanjeev, and I think you should comment on acetrom in pregnancy, and other from maybe Ankit, and finish with Dr. Sain, who I'm sure has a lot of experience.
Yeah, many of the unplanned pregnancy, they do complete without any teratogenic effect. As rightly pointed out, it's a rated kind of side effect, embryopathy. But it's a standard to avoid warfarin. So we had, in a planned pregnancy, we always tell them to switch to the heparin and then continue for the last trimester. And then.
So in a childbearing, if a surgeon were to implant a mechanical valve, you won't be happy, right?
Yeah.
Is that what you're saying?
True.
Sure.
Just make a quick comment, sir. The studies have shown that if the requirement of vitamin K antagonist is less than 5 milligram to maintain the PTINR between 2 and 3, the teratogenicity rate is very, very, very less. It is compared to the general population.
So can I?
In this room, there is a valve replacement experience of 5-figure cases maybe.
Yes. So that's why I said. So what?
And they have that's how we see a senior surgeon. If your well-replaced patients have delivered healthy babies, you are a senior surgeon.
So if my opinion would be, before replacing the valve, put this patient on acetrom. if the dose is less than 5 milligram to achieve that PT-INR, go ahead and put a mechanical valve.
You would? You would be happy?
I would be more than happy, sir.
So I have some hard data here. There's a study published by the Cleveland Clinic by Mihalovic, Tomas Mihalovic, and it shows that vitamin K anticoagulation in patients, the chances that there will be some problem is 3.9%. And this is a study over 998 patients, so it's close to 1,000 patients. The chances for a reoperation in a young, healthy female, let's say who's 35 or 40, after a bioprosthetic valve, STS risk score right now is pegged less than 2%. The other aspect which we have to take in mind is, with a mechanical valve, pregnancy is a very prothrombotic stage. It's not just about anticoagulation, it's also about prothrombotic state of pregnancy, wherein there is hyperviscosity, there is chances of thromboembolism, there is chances of stroke, there's also chances of bleed, there's also chances of spontaneous abortion because of microthrombi. So ESC guidelines say 2012, as way back in 2012, that class 1 indication, bioprosthetic valve, and the American guidelines don't have to say anything, they are mute about this.
No, in fact, the teratogenic effect is just thickening of some skull bone and some nasal bone and like that. In fact, the All India Institute, they studied this way back when we were students that time. And that time they found that nothing will happen and just continue. And that is particularly with the VARF. Acetylene has least chance or either almost nil chances of that.
Patients with mechanical valves.
Fortunately, our patients, most of the surgeons, we are following the acetylene. Because VARF is used in USA. Acetylene is not used in USA. So I suggest them to use acetylene in USA, so they will get away of this problem.
Ankit, would you want to?
By the time the pregnancy is diagnosed, it's already like 2.5 months, most of the times. So teratogenic effects in the first 3 months are already, theoretically there. So by the time the pregnancy is discovered, they are already on acetylene for 2-3 months.
So what would you do? Mechanical valve, bioprosthetic valve?
Mechanical, I'm fine with mechanical. Over a period of time, I'm seeing.
Dr. Srivastav,
yes,
mechanical valve,
good.
bioprosthetic valve. 100% mechanical in young. Dr. Mathur?
I cannot. I have to put a valve. If she wants a pregnancy, I have to.
Dr. Alok?
Repair and mechanical valve.
We are not talking about a situation where, repair is not a feasible option, sir. All right, should we move on to last question?
No,
I know my
bioprosthetic
cardiologist
valve
colleagues
also, there may be patients with atrial fibrillation, LA clots. In any case, you have to give anticoagulation in most of the patients.
There are some indications for anticoagulation where it cannot be avoided. That makes sense in that scenario. But we're talking about a generic
most
scenario.
Most of the patients are AF, large hearts.
One more thing I want to add, in Indian scenario, redo operation for a patient with rheumatic heart disease, most of these patients are poor, redo operation is not possible. One of my patients, I did LSCS with, my gynecologist did LSCS with mitral valve replacement with tissue valve. 5 years, 6 years down the line, she requires now redo replacement. She doesn't want it.
We did a redo replacement.
No, you did it. It is patient, social constraints are also there in our country.
Would you rather have them on anticoagulation? In the Indian scenario, patients don't take anticoagulants either.
They take anticoagulant, but redo operation in our setting when patient is poor, there are so many social constraints. Mechanical valve with lifelong anticoagulation better. I put mechanical valve.
Okay. Doctor,
if patient of childbearing age is ready for reoperation, go for bioprosthesis. Because teratogenic effects come later on, but initially I have seen that after conceiving there is high chances of abortion.
So the incidence of abortion, we are not talking about just deliveries.
Yes,
abortion is close to 6%. It's 6%.
Very high, very high.
Yes.
Yeah, please, Dr. Bhupati. So as much as you have a point there, Nagendra, Ross is not a very popular procedure because of the technical demands of the procedure, first of all. Most of the surgeons are not comfortable or conversant doing a Ross. That's the first thing.
I'm not a surgeon, so I'm just reading.
Second thing, in the infective settings, as well as in the rheumatic settings, the outcomes of Ross haven't been really, up to the outcomes comparable to mechanical bioprosthetic valves. So,
I have a very brief comment to make. most of our experience of our generation has been valve replacement. Women with childbearing age were quite common because that's the younger age group which we saw the rheumatic group. As far as I can remember, I have offered a bioprosthetic valve to only one person in my whole experience in the childbearing age. This was a couple who were adamant that they would have their own child, and they had been fully investigated, and they tried all sorts of in vitro things, and they said, we will continue to do so, so we want a bioprosthetic valve. As far as the rest of the patients of that age group in childbearing, I have more than enough patients who have born 2 or 3 children after the valve replacement. And they are the ones who haven't bothered to inform me even before the delivery takes place. In the sense, they continued on an imaginative dose of acetylene, which gave rise to a PNR of what
God is great.
PTINR of what happened, I don't know.
Right.
We did have abortions, and they came for that. But the number of pregnancies, mechanical valve and oral anticoagulant far, far, far exceed. But I am still very afraid of people who will say, I will put in a bioprosthetic valve at the age of 30. And there is a lot of young surgeons who are doing it now. This is a different controversy, I don't want to raise it, but this has to be discussed again and again because rough data is not available.
All right.
My experience, my emphasis, my.
Yeah, for the benefit of time, and there are 2 talks still remaining. Bhupati has traveled all the way. I'm going to cut the discussion short. I think we'll carry on question 3 over a glass of wine outside. So I'm going to cut this short and invite my next speaker. Thank you so much, ladies and gentlemen, for your attention.
Thank you very much for this wonderful scientific session. For the next scientific session, I would like to invite Honorable Chairperson on DICE, Dr. G.L. Sharma, Dr. Alok Mathur, Dr. Sohan Sharma, Dr. Ravindra Singh Rao, Dr. Gaurav Singhal, Dr. Neeraj Chaturvedi, Dr. Ankit Mathur. May I request all esteemed chairperson, please come and chair the session. Dr. Alok Mathur, Dr. Sohan Sharma, Dr. Gaurav Singhal, Dr. Neeraj Chaturvedi, Dr. Ankit Mathur. Dr. Sanjeev Sharma. Now I would like to hand over scientific session to Honorable Chairperson.
I would like to invite Dr. Nagendra Bhupati. Bhupati, thank you very much for traveling from Chennai. Bhupati is a very close friend, and those of you don't know him, he's an expert in intervention cardiology and structural heart disease. He's leading the TIV program at SRMC Medical College, Chennai. Bhupati, over to you. Bhupati is going to teach us selecting the right valve for the right patient, and I think that is the most important topic for the evening.
I hope the most of the audience are cardiologists. The last 2 sessions, majority of the sessions look Greek and Latin for the cardiologists in front of surgeons. We were all looking like toddlers when people were doing marathons. So let's discuss what we know. We were trying to learn what they are doing. Amazing work, especially what Dr. Buddhadev and Dr. Devaguru sir showed. Salutes to you, sir. With all due respect to the previous 2 speakers, I will pay my respect to the father of TAVR, Alain Cribier. So no need for me to go into the details about the evidence that is available that compares SAVR with TAVR. We all know Ravindra has multiple times told that ESC says 75 years, ACC says 65 years. Anyone who has got a severe aortic stenosis more than 65 years should be considered, at least should be given an option for considered for TAVR without sending the patient without even considering it. After 80 years, TAVR is the first choice irrespective of any comorbidities associated with or without it. For ESC, it is 75 years. The most important point is transfemoral access. That is the key. Doing a TAVR through other alternate routes have not been shown to have similar results as compared with transfemoral TAVR. Comparing valves is a difficult thing. These are all the current available valves. The valve that has been taken out of market is Lotus mechanical expandable valve. It has been taken out because of technical reasons. The company has accurate neo self-expanding valve. So this valve has been taken out. In India, other than these valves, all these valves are in United States and the Western countries. We do have other two CE marked valve. One is the My valve and the other one is Hydra valve. Data regarding these two valves are meager, so I will confine myself to US FDA approved self-expanding and balloon expanding valves. An ideal TAVR valve, just like any idealistic person, should be a small in size. We should be easy to deliver. Should not be more thrombotic. You should have tri-leaflets. It should not cause any significant coronary obstructions or pacemaker requirement. The contrast requirement should be low. It should not scrape the aorta that may lead to stroke. These are all the idealities that that a particular valve should have. However, most of us are not ideal. We live with kind of subnormal situations. That's okay. So evidence available to compare one valve with other valve is very, very scarce. Let's go through the evidence first. 5-year outcome of study by name Choice that compared Sapien XT versus a core valve, the first generation valve, showed that no significant difference by means of hard endpoints. However, the effective orifice area and the mean gradient at the end of 5 years was significantly lower with regards to effective gradient, and effective orifice area was significantly higher with regard to self-expanding valve. This is the second study that got published in 2020, Solve TRAVI trial. This compared the current generation. These two valves, XT and core valve, are out of market. So there's no use about discussing the particular trial. However, Solve TRAVI compared Sapien 3 versus Evolute R. Some of these patients have also got Evolute Pro. It also showed the primary endpoint, which is an amalgamation of death, MI, stroke, second valve implantation, kidney injury, showed that there's no significant difference. The primary outcome was assessed at the end of 30 days. So at 30 days, in this high-risk patients, there is no significant difference. There are other trials which are kind of which showed that a self-expanding valve by name Portico was equivalent to commercially available valves. However, the self-expanding valve first generation accurate neo was not even it failed to prove its non-inferiority with either Sapien 3 or with Evolute R valve. So accurate neo has been taken out of market. Now accurate neo 2 is available, for which the pivotal study is being conducted in United States. So this is the meta-analysis which was done by us when I was a fellow there in US. It's under review. I'm breaching the contract. I should not be showing this particular slides. However, for the sake of interest, this is what we did. We analyzed we compared basically between balloon expanding valve and self-expanding valve. We found that the all-cause mortality in high-risk patients who are symptomatic going for TAVR, we found that the all-cause mortality actually favored a balloon expanding valve. The thing is, we include all the self-expanding valves. All the self-expanding valves, technically they are the same, except Portico, which is an intra-annular. However, the other three are supra-annular. Other than this, there was no significant difference what we obtained. So we concluded that balloon expanding valve TAVR is associated with reduced all-cause mortality. It's a high level of grade evidence. Grade is technically it's a highest amount of evidence that we can give to a statement by utilizing artificial intelligence, especially for all-cause mortality. However, the level of evidence was very low for cardiovascular mortality. This cannot be extrapolated to intermediate or low-risk population. The major limitation of our study was inclusion of choice, which included core valve, which is out of market now. However, this question of comparing balloon expanding with self-expanding will remain unless we get a good number of randomized control study. So before selecting a valve, these are all the parameters I would like to consider: durability of a valve, annular size, landing zone calcium, coronary artery status, vascular access, ECG of the patient, and valve in valve. Am I doing a native valve or valvular TAVR? Durability. Let me go through the durability. This is the largest study available, Notion 8, published last year. It says that at the end of 8 years, with all due respect to surgeons, I may be saying something which is contradicting the surgical, my thoughts actually. Ironically, there is no difference. Ironically, the structural valve deterioration was found to be significantly higher with surgical AVR as compared with transcatheter aortic valve. This is the only study that has shown like that at the end of 8 years. There was no difference in the MACE outcome. This is for self-expanding aortic valve, self-expanding TAVR. That is Medtronic core valve products. The second one is partner two trial that compared second generation XT versus surgery. Also, it compared S3 versus surgery. It found that XT didn't do good. It was inferior to surgery. However, S3 did had a same kind of structural valve deterioration with SAVR. These are the two slides that I showed to my patient. These are the data available. At the end of 5 years, it has been shown. At the end of 8 years, it has been shown. After that, we don't know what is going to happen. So let me go with this particular patient. This is the regular TAVR patient, not big. Any kind of valve will be suitable for this particular patient. He didn't have any ECG abnormalities. Gradients are quite high. Coronaries were clean. Anatomy says the area of 402, which favors a 23, say, balloon expandable valve on perimeter of 72.3 that falls under 26 balloon self-expanding valve. Every parameters were okay except for mild septal bulge. If septal bulge is going to be there, the valve may get embolized on the aortic side. We have to keep a good amount of push to hold the valve. Femorals were clean. All of us would agree that because of want of time, I'm rushing fast on the initial slides. All of us would agree that any valve is going to be suitable for this particular patient. This patient had a self-expanding valve. He got discharged a couple of days later. He's doing fine. ECG remains same. Currently, in order to decrease the amount of pacemaker requirement, we are using cusp overlap technique, which was done in this particular patient. Gradients are fine. The annular sizing. We have limitations with annular sizing. We have to accept that we cannot do TAVR for all the patients. The annulus is quite small. It is surgical work. The annulus is quite large. Again, it's a surgical work. There are limitations for both balloon expanding and self-expanding valves. However, balloon expandable valve can be expanded out of its IFU instruction for use. By adding every 1 cc, I will increase the diameter by 0.5. Having said that, usually we can go. It's all off-label indications. We can add 4 cc to increase a 29 to 31. Anything more than 31 is kind of very risky to do with a 29 valve also. Similarly, for small annuli, chances to have a severe PPM is going to be higher with the TAVR valve. So the patient may need a root work to make it big, whatever the commando work, whatever the previous speaker has shown, to get a better long-term outcome. But if the patient is a high-risk candidate, in such situations, maybe a self-expanding is preferred so that we can have a supraannular nature leading to better EOA and a lower mean gradient. A landing zone calcium, of course, it has got its own, it's a double-edged sword. If you put a balloon expandable valve and go and deploy it, chances for us to have an annular rupture is going to be on the higher side, especially if the calcium is going to sit on the non-coronary aspect. If you deploy a self-expanding valve, chances for us to have a PVL is going to be on the higher side. However, I will err on the PVL side rather than on the annular rupture side. I will go, okay, this patient, annular significant thing, if it is going to be a more than a moderate, I will do a post-dilatation. If not, I will come out safely, that's it. Here is a patient, 84-year-old retired physician, severe LV, low flow, low gradient, intermediate STS, high risk due to age and frailty. This is the anatomy. I would request Ravinder to select what is the choice for this particular patient. 84-year-old, frailty, post-cabbage, patent graft, severe LV. This is the anatomy.
CT scan presentation, this calcium, what it is telling me, high chance of annular rupture if I need a perfect result, high chance of LVOT problem, high chance of complete heart block. So I want to select a valve which is self-expandable and has got a skirt on the outside, and I would prefer not to do post-dilatation if my patient has less than mild or less than moderate paravalvular leak. So my plan in such a patient would be a self-expandable Evolute Pro valve. Can I see the coronary height, Bhupati? I didn't pay attention.
He is post-cabbage patent coronary.
No doubt about it. I'll use an Evolute Pro valve.
Exactly, yeah. So that's what we did actually. One important point is we are not used to have the 3D anatomy of the heart, unlike the surgeons. So this is the non-coronary cusp. This is the left and this is the right. Whenever you see a calcium in the non, the valve is not going to expand in this side. Exactly opposite to this is the side where the valve will expand. Unfortunately, this part of aortic valve is not supported by a good amount of fibrous tissue or a membranous septum. So this is supported only by a muscle. So that is the reason why this whenever the calcium is located from this non-coronary aspect, it will expand on the opposite side, which doesn't have a good amount of support. That leads to annular rupture. So that especially with non-coronary calcium. This patient had a self-expanding 23 valve, went home a couple of days later. So vascular access size, I would say you have to be very clear with. We used to go through the CT scan on our own to prevent possible complications. Still, it may happen. It will happen. But if we can avoid such complications, you should know when to select which valve based on the vascular anatomy of the particular patient. He is an 80-year-old male. Lot of comorbidities. We are going through the comorbidities. He has got a low flow, low grade aortic stenosis. He is planned for an. This is the anatomy of the particular patient. As I told earlier, he's got a nodular calcium. We classify the calcium based on mild, moderate, severe. Whenever a single amount of calcium is going to be there protruding more than 50% into the LVOT, it's called a severe calcium. That's a nodular calcium. One calcium is good enough to cause good amount of PVL or annular rupture. So in this particular patient, we can because of severe PAD and a nodular calcium, a self-expanding valve is definitely preferred. And we need to tackle such anatomy because of severe calcium. Even in the CFS side, ultrasonogram access was obtained, and we always see such kind of dangerous PADs. We used to protect with the opposite side up and over peripheral wire, and we did an IVL for this particular patient. Following which we could deploy a Evolute Pro valve safely without any issues. So coronary access, I will take 2 more minutes. With this, I will stop. Coronary access is very, very key. This is a paper published last month in Circ Intervention. This says that they compared coronary re-access with Sapien, Evolute, and Accurate Neo. They found that there is something called as commissure alignment with the self-expanding supraannular valve, which cannot be done with balloon expandable valve. They found that all the coronaries can be accessed with Sapien valve. However, 3% coronaries cannot be accessed even with commissure alignment with the supraannular valve, and 11% coronaries cannot be accessed at all. And 26% is going to be non-selective. We don't know whether we can access or not. And 43% will be non-selective. We don't know whether we can access or not. It's basically a post-CT assessment of such patients. So when you handle a patient who has got a significant CAD, I would suggest to go with the balloon expandable valve because we don't know when the particular patient will need an intervention. This is a patient, 87-year-old male. He had I will go through the angiography later. He has severe AS with CAD with the left main and TV anatomy. This is the left main, and this was done in Mount Sinai when I was a fellow there. This is the left main and severe critical RCA disease. So this patient, we did a BAV with a 18 millimeter balloon. Impella was placed. And following Impella, there was no hemodynamic compromise occurred at any point of procedure. Burring was done with 1.5 burr, and meniscus technique was used to put stents in this particular patient. End result was reasonably okay. And then RCA was done in the same setting. And a month later, Sapien 3 was deployed. You can appreciate wire was actually put inside the coronary without a guide liner. This can actually backfire if the sinus tubular junction is not big enough. You may not be able to take a stent inside. So because of good amount of dislodgements that can happen whenever you are not going to have a guide liner inside, we don't keep stents. Provided the STJ is good enough to take a stent. Everything is assessed pre-op by the CT scan. So valve in valve situations. Let me go through this. Yeah, here's a 65-year-old gentleman. Severe aortic stenosis. 10 years, 2013, he had a AVR done. He had an angina, recent angina, evaluated, found to have severe aortic stenosis, restenosis of the bioprosthetic valve. He is a past public servant worker. So we have to be very clear, categorically telling that you are a candidate for surgery, whatever it is. We have done video counseling also. After that, he declined to go for a cabbage with AVR. He had an tight RC disease. Hence, a TAVR was planned. TAVR was peripheral access was nothing we could manage such issues. This is the osteal RTA disease. You can appreciate a 90% tight osteal RTA disease. in spite of having intermediate risk, in spite of telling them that he may go better with a surgery and AVR, he preferred TAVR. Hence, we plan to go for a GA TE guided transfemoral TAVR with PCA to RCA. Usually, valve in valve is better to have a GA TE done, so that you know what exactly any problems can be diagnosed very early stage itself. We dilated the RCA, created a good amount of lumen, and we didn't even park a stent, we just kept a wire. Later on, routine stuff, we crossed the valve, dilated, measured the gradient, dilated it. Patient had a severe AR after dilatation. I wish I should not have dilated, but there was severe amount of gradient. We took almost 15 minutes to even to cross the valve, and multiple catheters were used to go through the valve with the wire. At that time I thought, okay, let's pre-dilate it. However, post pre-dilatation, he had a significant AR. We were hurrying to put the valve in. After valve in, you can appreciate a mean gradient of 15 millimeter mercury. This means we need to do a BVF bioprosthetic valve fracture or remodeling in this particular patient, which was done, following which the gradient dropped down to mean of 7 or mean of 6. So later on, we did a PCI to RCA in the same setting. This is the only situation where I would say a balloon expandable valve can be preferred other than self-expanding valve in a valve in valve situation. Otherwise, it's always self-expanding valve which is preferred in the setting of valve in valve TAVR. This is my perspective about selecting a valve in a patient who's having a native TAVR or a valve in valve TAVR. There is no guidelines as of now. We go with our personal experience and how we have been taught. 90% of the time, please take it from me, you will be right irrespective of what you put, whether balloon expanding, self-expanding, but it is only the 10% of the time that determines your career. One annular rupture is good enough to crash the program. With this, I would like to conclude my talk. Thank you. Sorry, I have to be in a hurry. I have to finish it fast so that we can have an early dinner.
Thank you so much, Bhupati, for considering the dinner part. But great talk. Just one question for all of us. Now, suppose if somebody is starting a program, would you suggest them to start with balloon expandable, self-expandable?
Whatever the way the proctor is going to come, if they are going to run the program, 90% of the time I would say you can select either of the valves, especially in our setting when the cost is a significant concern, we can go with either of the valves. Based on the proctor, if he is comfortable with self-expanding, self-expanding. If he is comfortable with balloon expanding, balloon expanding. But whatever the parameters I told, please assess those parameters. Patient has got a severe TVD, even a left main disease, even a double vessel disease. That guy is going to have the restenosis later. And I have seen a senior most operator whom I know, he was not even able to engage. And we have to leave the 95% RC, it is just like that. So that can happen to all of us in future. We are going to encounter more and more TAVR related non-accessible coronary problems later.
Great talk, Dr. Bhupati.
Thank you,
Just I want to ask two short questions. First, what you mentioned, the age criteria for SVR and TAVR is 65 years. If surgical turn-down patient, what is the age criteria for that? And second, you mentioned self-expandable, there are less chances of calcium cracker. So cerebral protection is not required in self-expandable, or it is only required in balloon expandable?
To answer your first question, anyone who is going to be more than 75 years by ESC or more than 80 years, clearly it is TAVR. So that it's a kind of surgical turn down. I hope I got your question right. You asked me the same question. No, 65, less than 65 years. I would ask myself, why am I turning down? Why am I turning down? Is he a liver transplant? Is he something else? Is he an inoperable guy? I want it to be documented. We don't know when I can be shoot. I'm honestly speaking. So I want it to be documented. Why am I doing it in a young age? In those situations, if the patient has got a liver transplant to be done, where none of us, most of you agree, being a surgeon, most of you agree that it's very difficult to handle a pre-transplant patient, liver transplant patient who is in full coagulopathy. That's the only situation, or a kind of pure aortic regurgitation, infected endocarditis, complete sepsis, whatever going on. It's a kind of a desperate, compassionate situation. Otherwise, it's not indicated. Second question, sorry, sir. Cerebral protection, yeah, there's a randomized study that has been done. There is no use of cerebral protection device. It is called a Sentinel. Device name is Sentinel. Study name is Sentinel. Sentinel ID is the study. that showed that they randomized 350 patients and did MRI for patients without sentinel, with sentinel. MRI based study was positive. Patients who received sentinel, it prevented microemboli. However, it prevented macroemboli. However, microemboli still happened with sentinel. 98% of the time, they observed the muck that has been captured by the sentinel. There was some particles. It doesn't matter. It is only the balloon dilatation that matters. If you balloon, most of the time we can balloon. Most of the time, if you are not going to do a pre-BAV before a self-expanding valve, you may end up doing a post-BAV. So it is the balloon that matters. Thank you.
Thank you, Bhupati.
Thank you very much, sir, for this. Thank you very much, sir, for this wonderful scientific talk. May I request to esteemed chairperson, please present memento to Dr. Nagendra Bhupati. Please. Dr. Nagendra Bhupati from Chennai. Thank you very much, sir. Request to all of you, please take your seats. And for the next scientific session, I would like to invite Honorable Chairperson on dais, Dr. Ramesh Patel, Dr. C.P. Srivastava, Dr. Sanjeev Sedana, Dr. Lokesh Agrawal, Dr. C.B. Meena, Dr. V. Devguru, Dr. R.K. Gokuru. Request to all of you, please come on a dais and chair the session.
I will keep it very, very short. I'm going to skip majority of my slides. Can I have the slideshow, please? Because, we all are very hungry and I don't think so our neurons can take it more than this. So, transcatheter mitral valve therapies and TAVI. I think we have spoken a lot on TAVI already. I'm going to talk a little bit about transcatheter valve therapies. These are our colleagues at RHL Heart Center. That's me, Dr. Pawan Mehta, an excellent intervention cardiologist. Dr. Prashant Varshney, he's a cardiac anesthetist and cardiac critical care specialist. The reason I'm highlighting this slide, in order to run a TAVI program, in order to run a structural heart disease program, you need to have a cardiac anesthetist in your team. That's very, very important because a cardiac anesthetist thinks on the line of a surgeon. You do the TAVI and post-procedure hemodynamics, it has to be managed by a cardiac anesthetist. And that is what we do in our practice. He takes care of all our TAVI, mitral clip, cardiogenic shock and impella patients. No disrespect to general anesthetists, but a cardiac anesthetist has got a better perspective on cardiovascular hemodynamics, and that's where he has learned from the cardiac OT. These are procedures which we did. I mean, most centers would have done more than us, but we did 447 PCIs, ROW is 65, IVL 22, TAVR or trick valve was 63, 8 mitral clips, and endovascular devices were 2. So we had patients for TAVI who traveled from all across parts of India. We had patients traveling from Dubai as well as Bangladesh. So coming straight to the presentation of transcatheter mitral valve therapies, mitral regurgitation, functional mitral regurgitation. My topic will be focused on mitral clip. Mitral clip, for those of you who don't know, it's a standard thing. We go from the femoral vein, right atrium, left atrium, and clip the mitral valve. This is like a Alfieri stitch, which surgeons have been using it. The only the only thing which is not there during mitral clip is cardiopulmonary bypass machine and a real-time 3D TE to assess the effect of mitral clip. So this is the data from the COAP trial, a highly effective study which showed statistically significant lesser death in patients who underwent mitral clip for functional mitral regurgitation and improved quality of life compared to medical therapy alone. So this is very important. We need to select our patients based on the COAP trial, maximal medical therapy, addition of an ARNI, diuretic, beta blocker, SGLT2 inhibitor, CRTD if required, and still patient has a mitral regurgitation, patients can be treated with mitral clip. The very important thing is these patients were enrolled based on transthoracic findings, not on a transesophageal finding. So selection of patients was based on transthoracic finding. Transesophageal was only to assess the suitability for a mitral clip. Even patients who were having heart failure symptoms and underwent mitral clip procedure, they did not require cardiac transplant, almost 30% of these patients.
68-year-old male, post-cabbage 2020, residual severe MR, NYHA class 3, hospitalized 5 times in last 6 months, and last admission for almost a month, was transferred from UP on Milrinone and Norad. Now this is a very important question. We were listening to all our surgical colleagues, the importance of ischemic mitral regurgitation when the surgeon is doing a cabbage. So standard transeptal puncture, 3D-TE is very important. And here you can see the orientation of the mitral clip. This is the surgeon's view. You can see the mitral valve from the left atrium side, and the mitral clip is deployed. And post mitral clip deployment, there is residual trivial mitral regurgitation and a double orifice mitral valve with mean gradient of 2 millimeters of mercury. And this is how it looks like on a 3D-TE. And you can clearly see how the clip is there on the A2P2 double orifice mitral valve. And this patient was discharged on 5th June and has not been readmitted since then. Similarly, a 66-year-old gentleman, post-cabbage, sorry for that spelling mistake, severe mitral regurgitation and flail leaflet. You can see on this TE picture, you can see how flail the anterior mitral leaflet is. Again, on the 3-chamber view, a flail anterior mitral leaflet and 3D picture. A mitral clip was implanted. And you can see how the clip's arm are there. After deploying one clip, patient still has residual mitral regurgitation, and we went and deployed the second clip. And you can see how the second clip looks like. One clip at A2P2 and the second clip medial to the A2P2. And post deployment of 2 clip, trivial mitral regurgitation. Very interestingly, this patient's creatinine came down from 3.6 to 1.4. He had not slept in last 1 month. Post procedure, very same day, he was able to lie down flat, and we discharged this patient home on 4th day. So clearly, as I highlight again, you can see double orifice, trivial mitral regurgitation post procedure. This is how it looks like on fluoroscopy. But if you can see that pigtail catheter, when we are doing a mitral clip, you can see the pigtail catheter which constantly measures the left atrium pressure. So those of you, if you can appreciate Himalayan V wave, which indicates severe mitral regurgitation, and once the mitral clip is deployed, the V wave comes down and the LA pressure from 90 has come down to 24, and that's what made the difference. So if you look at the history of both the patients, they are functional mitral regurgitation post-cabbage, and that is the role of mitral clip. TMVR, we discussed valve and ring, we discussed valve and valve, and I'm going to also discuss a valve and MAC. But this is a standard. We would do a transeptal puncture, go inside the left atrium, go inside the ring or a valve, do a rapid pacing, and deploy a balloon expandable valve. And this is how it looks like on fluoroscopy and on TE. A mitral valve, functioning mitral valve, and mean gradient of 4 millimeters of mercury. Similarly, valve is positioned in such a way that it is more ventricular and less atrium, and imaging is very important. For all mitral valve intervention, a TEE, especially with a 3-dimensional TE imaging, is important. Now this is what we discussed about mitral annular calcification. Expert surgeons might be doing it, multiple techniques, but what do we do for a mitral valve, mitral annular calcification? We do a detailed CT scan analysis. You need to look at the mitral valve MAC area. Importantly, you need to look at the LVOT area, and will the LVOT get occlude when you deploy a valve? Here's an example of a 52-year-old patient, severe AS, severe MS, MAC, porcelain aorta, Hodgkin's lymphoma, chest wall radiotherapy, sinus rhythm, first degree heart block, RBB, LAHB. And why this was a surgical turn down? You can clearly see. Look at the ascending aorta, arch of aorta, aortic valve, and the calcification. So these are young patients who are surgically not high risk, they are inoperable. So this is actually a prohibitive risk, and that's why we would do TAVI in such patients. So the aortic valve was replaced first, and then a valve in MAC was done using a 29 Sapien 3. This is a post-procedure gradient of 2 millimeters of mercury, and this was all transcatheter, and this is how it looks like on 2D echo. So this is what I was discussing. Look at the mitral valve, how close it has gone to the LVOT. Now if this LVOT was small, this patient would have developed an LVOT obstruction. This LVOT, neo-LVOT, predicted neo-LVOT area was 275 millimeters square, and that is why this patient developed, was stable. This was the first double valve replacement of the country. TAVI, Bhupati has already discussed, so I'm just going to discuss our own published paper. We have done total cases which we have done here in Jaipur is 180. At RHL last year we did 63 cases. Sapien 25, Myval 22, Evolute 12, Portico 1. I'm also visiting cardiologist at Leelavati and Breach Candy. We have done 151 combined cases, Edwards 51, Medtronic 35, Merrill 65. This is a certain scenario where we're doing a Sapien 3 with coronary protection. You can see a low left main, a stent is parked in the coronary arteries, and an aortic valve is deployed under rapid pacing. Once the valve is deployed, and if patient does not require a coronary stent, the coronary stent is removed, and this is the final angiogram. And this is again, as we were discussing, this is a 61-year-old Urmila Devi who came from Nasik. This patient has cirrhosis of liver and is pre-op for liver transplant. Importantly, we have done a patient as young as 27 years because patient was pregnant. She was in her last trimester. She already had 4 abortions. So surgery during pregnancy does not carry a high risk for the mother, but the child was precious. We did a TAVI, patient has delivered a baby girl, she's almost 1 year old now. So young patients, we need to have a clear-cut indication why we are doing a TAVI in patients. Valve in valve, Bhupati clearly pointed out an evolute R with a supraannular positioning, but the way the valve is positioned, you can see it has to be as a 0 depth, and then only you can gain that benefit of a supraannular position. New valves, Portico, we did the first case in the country. This is from Abbott Vascular, and one advantage of this valve is a very flexible catheter, and it can go through the smallest, it is the smallest profile valve. It can go through as small as a 5 mm valve. Here is an example of a very horizontal anatomy which we did this valve replacement. But these are just few last slides. Sometimes things don't go as we plan. So I'm going to show you one example. So we deployed a 26 mm Sapien 3. Immediately patient developed hypotension, massive pericardial effusion. Can anybody guess what's going on here? Yes. So this patient has developed annular rupture, and what do we do immediately? We call Buddhaditya. We called our surgeon. So the OT is ready, everything is ready, and one person does a pericardial tapping. We did a pericardiocentesis. That's why when you're doing a TAVI, the preparation has to be as if you are doing a surgical AVR, not as if you're doing a PCI, and you have a cardiac anesthetist. So the OT is ready, but so everybody's getting ready. I said, give me maybe 1 or 2 minutes, that's all. So we decided to do something percutaneously, and I was able to wire this perforation, and I did put a coil in this patient, and you can see I'm coiling the perforation. By this time, we are also doing a pericardiocentesis. The pericardial tap was done, the blood transfusion is giving, the OT is getting ready. By this time, everything is getting ready. But I was able to coil it, and after coiling, this is the angiogram. So no leakage, the annular rupture was sealed, there was no pericardial effusion. We kept the pericardial, pigtail in the pericardium for 24 hours. Patient was discharged home safely. And this is the first case in the country of a coil repair percutaneously for an annulus rupture. But the reason I wanted to highlight this case is now when you're doing a TAVI, see, as I said, 90% of time it's going to be fine, but we need to be prepared for that 10% of times. So if I would have taken a little longer for this, I would have sent this patient for an open heart. But you can't send the patient too late, because if you send the patient too late, even the surgeon will not be able to do anything. This is again the last slide, which Bhupati always pointed out. I also stressed, if it is a TF TAVI, it is a class 1 indication. And this is how the TAVI looks like nowadays, percutaneous, no Foley catheter. Nowadays we are getting rid of central line also, and totally percutaneous proglide based sutures. Take home message, we need to differentiate between high risk TAVI, low risk TAVI. Low risk TAVI results should be equivalent to surgery. Minimalistic, but be prepared for maximalistic. TMVR for valve in valve is already FDA approved. Mitra clip for the right patient improves outcome and mortality. Thank you very much for the kind attention. I think 5 minutes jaldi khana mil sakta hai. Any questions?
Ravinder, there was a annular rupture. So can anything be done for larger rupture, like this was a small rupture, you could coil it? Anything percutaneously could be done?
So, I mean, you can't, number one, that's a very good question. I've done it for the first time. I've never done this, but I was able to think it and we were able to coil it. There are certain cases which is reported. But I said, if you feel it is a large rupture, send the patient for surgery. So you can do multiple things. You can pass a catheter, put a coil, put a device closure, put a implanter plug, put a occluder. But remember, you are close to the aortic annulus. So bigger the device, poorer the outcome. The reason this sealed off the rupture was like a funnel. So the tail of the coil is into the tract, and you can close the mouth with the rings. But I would say, we were lucky that you can also argue how can this hold it against such a high aortic pressures. But this patient has completed almost 3 to 4 months of follow-up.
But what surgery Buddha would have offered? Buddha, इसमें क्या surgery offer करते? Like removal of the this thing, huh? नहीं, वो तो है.
So we have seen such surgeries in US. So first is don't remove the valve. Again, one more just a advice to all our new operators. I believe everybody will be doing TAVI in next 5 years. So when you are doing a TAVI and your patient develops hemodynamic compromise, what you do the first thing? You deploy the valve. Never come out without deploying the valve. Because if you deploy the valve, that's how this patient is going to improve. You correct the aortic stenosis. Now your surgeon does not have to replace the valve. He has to correct those things. Otherwise, he'll end up doing an AVR plus the correction of the complication.
No AVR required then, huh?
Not as yet, but we'll figure out the day we get in.
Someday it is going to happen. Statistics never lie.
Yeah.
If 1 in 1 lakh angiography dies, it will die.
So I always have bovine pericardium and trifecta on my shelf.
Yes.
Okay. So cannot be approached from outside, huh? You can just repair the rent from outside.
Yeah, that's what I was thinking.
One more thing, Ravinder.
Maybe.
I've seen you putting stent in the coronary to prevent the coronary occlusion. So does stent have so much strength that it can actually keep the coronaries patent?
So that's a very good question. Why do we protect it with the coronary stent? The way coronary occlusion happens is by displacement of the native leaflet. So that's why the stent has to be parked in the left main or LED. So then you pull back the stent and you deploy the stent, it will displace the native leaflet down. It is not the TAVI valve which is doing it. If you don't protect it with the stent, you will not be able to cross because leaflet is right there. So you always park your stent and then pull back to protect the coronaries.
So does stent have enough strength to
Yes, that's also a very good question. So that's why you use a stent with a good radial strength, and sometimes suppose the sinotubular junction is narrow, you can reinforce it with another stent. Interestingly, you can put this stent to kind of salvage, and then you can go through the cell of the valve so that you can put a straight stent. I think we move on to the case presentations.
Thank you. Yeah.
So.
So we have the last session for today's meeting, and this is TAVI case presentation session 2. For the first TAVI case presentation, I'll invite Dr. Sohan Kumar Sharma, who is Associate Professor at SMS Medical College, Jaipur. Dr. Sohan.
Good evening, everybody. As we have all seen a lot of TAVI cases, so I want to focus only 2 or 3 important points. In any structural intervention, pre-procedural planning is very important, as so in the case of tower also. I heard in some presentation nearly 2/3 of the weightage of the pre-planning of the procedure. And second part is the vascular access issues during the TAVI procedure. So I focus on the vascular access in my case. And third is routine follow-up. So this is the case summary. I'm going, Mr. SL, 66-year-old male, presented with complaints of progressive dyspnea on exertion with angina on exertion class 2 since last 12 months. In the comorbidity, CKD stage 3 and COPD. Height and weight is helpful in risk score management. And ECG is sinus rhythm with LBB, X-ray chest, emphysemeter changes. And echo, there is a severe degenerative AS. with LV dysfunction. EF is 25%. Dobutamine stress echo was done. There is a good contractile result. This is the risk score of this patient. STS and Euroscore is in the intermediate range. Frailty assessment was done on the basis of these scores. Dr. Sen has asked in previous presentation if the patient's mental status is not appropriate, then what is the assessment tools? There is a MMSE risk score for these group of the patients. These are the various exercise done in a patient. CT scan was done according to the TAVI protocol, and various like height of the coronaries, annulus diameter, aorta diameter, and peripheral vessel diameter all were assessed. And there is a specific software for assessment of the annulus diameters and peripheral artery disease, peripheral artery excess diameter assessment. This is the risk assessment before doing the procedure, and now it is indicated for intermediate and high risk patient. We all aware about the STS score. There is a frailty assessment is also there. If it is 1, then it is intermediate risk. If it is more than 2, then it is high risk. It is based on the various points, and major organ system compromise not to be improved post-operatively, like 1 organ system or more than 2 organ system. It is important, like if the patient having inflammatory bowel disease, patient having carcinoma and other disease besides the cardiac disease, then it is important to decide before and doing the procedure. And procedure specific impediments, like if the patient having porcelain aorta, or if the patient having chest radiotherapy and is not able to operate it, then it is prohibitive risks. Definitely there is a heart team approach in these cases. I am going on the case. This is in our case. First taken the left femoral artery and vein axis. Balloon tip TPI was placed in the RV. Why balloon tip? To prevent the damage of the right bundle. And 5A pigtail was inserted through the left femoral into the right common artery. Right common femoral artery, and angiogram was taken for the right femoral arterial axis. Right femoral artery axis for TAVI was taken. This is very important slide for taking an axis in these patients. This is the, if you see the slide, there is a, this is the inferior epigastric artery is there. It forms the upper boundary of the safe axis site, and below there is a division of the superficial and deep femoral artery. So in the angiogram you see very well, there is a division of superficial and deep femoral artery, and this is a safe site for taking a puncture for large bore axis, I can say. And now there is a insertion of large bore sheath through right femoral axis, and an important in deployment of the valve is a determination of the coplanar angle, that is all the leaflets in a same line. That is already decided on the CT autogram, but there is a to determine during the procedure is the right cusp rule. If the ring is the primary target for transcatheter heart valve sizing and placement, obtaining a fluoroscopic image in which all 3 cusp bases are in the same plane is critical for proper positioning of the heart valve. This coplanar angle can be predetermined using CT angiography. However, due to the patient motion, placement and overlapping structures, the angle often requires minor adjustment. Generally, recommending to start with the 10-degree LO and 10-degree cranial position. In this, there is a right cusp rule. If the right coronary cusp is in the red, overlap the non-coronary cusp, you just turn the RAO. If it is, then ideal coplanar view means all 3 cusps are in the same line. If right coronary cusp overlap with the left coronary cusp, turn the LAO. And if the right coronary cusp is means deeper, then turn caudal. If right coronary cusp is other cusps are deeper, then turn cranial. So it's little bit modification of the view. Ideally achieve the coplanar view. As in our case, this is the, we're just adjusting the view angle, and this is the, you see in the angiogram, all three cusps are in the same plane. This is demarcated by this line on right side. This is important for valve positioning during the procedure. Now the same things crossing the valve with the straight tip wire, and with the help of various catheters like AL2 in this, and crossing the valve with a super stiff wire, and then place balloon dilatation with 2340 mm in our case. And this is the balloon expandable my valve, 29 mm. The placement done in and check angiogram was done. And there's a balloon, there's a dilatation was done, and there's a placement of valve. And post valve placement, the angiogram showed no paravalvular leak, and both coronaries are flowing well. And after completion of the procedure, again the important to keep eye on the vascular axis. There is a check angiogram done, and with the wire and probe glide in the position, we do a check angiogram to see any local site complication is there or not. So vascular axis site analysis after sheath removal is important in this procedure, particularly large bore procedures. So it is okay. So this is a successful tower done under LA with sedation after almost 3 years completed. Patient LVF initially was 25%, now it is 48%, and patient is doing fine.
Excellent case, sir, and very rightly pointed out that the case is not over until the vascular hemostasis is achieved. Any vascular complication is associated with increased mortality and morbidity in such patients. Any questions? I think everybody is tired. So probably we move on to the next presentation by Dr. Danny Manglani, who is again an enthusiastic and a senior intervention cardiologist at Gitanjali Hospital, Udaipur. There is also his head of cardiac surgery, Dr. Gandhi, also here, right, sir? So they are a hard team there. So over to you, Dr. Danny.
Very good evening. Thank you, Dr. Ravindra Rao, for inviting. The 90% audience has already joined the dinner, so we have to join in a rapid way. So at Gitanjali, me and Dr. Ramesh and Dr. Gandhi started this program, and we had done 4 TAVI till now. So this was the last TAVI we did, and this is 75-year lady with diabetic for last 10 years. For her age, the diabetes was fairly controlled. The HbA1c were ranging 8 to 9. She had a nephropathy, creatinine 1.8 to between 2.5, ranging in last 6-month reports. She started having a breathlessness class 3 4 months back, and she is diagnosed to having a severe AS, ejection fraction 30%. The gradient with the low EF was a 60 by 35. Dobutamine stat was already done. That was your severe AS. And on diuretics, she was class 2, and ST score came to intermediate risk for the further opinion. So TAVI was given for her opinion, and she opted for that. This is the echo images. This is the 3-dimensional report of CT. That shows that the perimeter and the area diameter was nearly same. So mid-range my wall was choose, that was 24.5. And the coronary height was definitely very good. And this was the other dimensions that was also suitable for the patient, the annulus dimension, the alveoli dimension. So this was basically was not a very high risk TAVI, it was a relatively low risk TAVI case, and this was the implanter angle we get. And axis definitely was there no significant calcification, there's no tortuosity, the vessel's diameter was 7 to 8 mm. So first we go for coronaries, it was a normal. The routine procedure from the left groin, we go for a pigtail, and then we get for a fluoroscopic guided puncture at the right groin, and putting the TPI and root shot. That shows the angiogram. And this was the usual, the crossing, because it is the most unpredictable step. It's a higher frame rate, and the crossing is a time that is not predictable. It's sometimes can take 5 minutes, sometimes half an hour. So but the changing of catheter is also helped, but we are able to cross it with a simple AL2. But you can just see that the changing the position of catheter helps the crossing the wire. We tried for 15 minutes initially, but was not crossing. But in the last, just we change the catheter position, and then yes, this change it and just cross it. And then definitely the routine procedure, we took a gradient, and then this pigtail was replaced by the sapphire wire. The wire can be used according to the operator. And this is the tracking of the myval. And this was the deployment. And after final position, we deployed the valve. And finally, we get a good result of this valve. This was the final angiogram. So, because we at Gitanjali are beginner, the high risk TAVI was not chooses. It was the low risk TAVI case, and we succeeded it. The ejection fraction is markedly improved. Presently, is a 50%. 1 year follow up is there. Groin shock last definitely is taken. Thank you, sir.
Excellent case, Dr. Danny, and great outcomes. Just one suggestion for whoever audience is left here. Huh? Yeah. So just one suggestion: when you try to cross, sometimes we try to go very fast.
It's a high frame rate because it's a long run. So I put it a high frame, but it's smaller.
Great. Fantastic, fantastic. Yeah. Any questions? Yes. So that's also a good observation. I didn't pay attention.
Yes.
The TPI preferably should be
balloon tip.
Yeah, but that's great presentation. So we move on to the last case presentation, Dr. Ramesh Patel from Gitanjali Medical College. And first of all, thank you all for traveling from Udaipur. By the time you set up, I'll ask a question to Professor Devguru. How do you see, sir, if this valve or any TAVI valve you have to explant in future, what challenges are there in your mind?
I think it will be easier than a routine because these are almost stentless. We have a stent placed in all the valves we have, bioprocesses or mechanical. That takes a lot of time, not to injure any of the surrounding structures. I think it will be easier. Pull it down. Some endothelialization does happen, but I think we'll be able to take it out easily.
Good evening, everyone. Thank you, sir. Thank you for revolutionizing this beautiful treatment in India. So I will not take much time. My case is straightforward, where we have a patient, Mrs. PS, 74-year female. She was having comorbidities, diabetic, hypertensive, and Parkinsonism. She was having symptoms for last few months, and we did echo. It showed severe calcific aortic stenosis with peak gradient of 74. Her coronary angiogram was normal, and after a discussion with family, we proceed for TAVI procedure. Here is that 3-mention report. We can see that her perimeter derived diameter was 23.6, and area derived diameter was 23.3. It was a tricuspid valve with a moderate level of calcification, but the aorta was horizontal. The only problem with this case was that left coronary height was 8.8. It was not just as Dr. Ravindra has already told us that more than 12 is good, less than 10 is a bit dangerous. Whereas the height on right coronary side was okay. When we see the femur access site, they were not non-calcified, not tortuous, straight vessels were there, and were voluminous, so there was no issue with going with femoral route. So here is the first angio where we have taken aortic root angio, and we can appreciate that left coronary was on height. Left coronary height was on lower side. So as usual manner, we have crossed the aortic wall with the help of AL and straight tip Teramo. And the way we used to do TAVI, that we have changed with pigtail, hard wires. First of all, we dilated this wall with a mammoth balloon, 20 to 40. And at that particular time, when we were dilating, we checked that whether we are going to occlude that left coronary ostia or not. At that time, we take angio. The plan was that if we are occluding that left coronary ostia, we will terminate the procedure and will send that patient for surgery. But this was encouraging for us that the balloon did not occlude that left coronary ostia, and we proceed with the our plan. But before that, we still went with the one support that we should kept JL guide at the left ostia and crossed we kept we park a stand in the middle of in the mid LED in the view if in case we occlude the left ostia, we can bail out that patient. And at last, we have completed that procedure with the help of the MyVal 26 valve. We crossed the lesion. There was a bit difficulty because it was a horizontal aorta, with some effort we crossed it, and at last we positioned it in a proper manner and finished that procedure without any complication. So this was final result. The valve has been is functioning properly. Left coronary ostia is okay. And at last, while finishing the procedure, we checked the iliacs, and we found that there is no damage we have done at that side. That's all. I think this case simply tells us how we have protected left system. So I think you are the expert person. So you are going to tell us in a better way at that part where we have tested that with the help of a mammoth balloon.
So Ramesh, excellent outcomes and great case and great planning. So that again brings to that point which I had stated in the CT scan talk. If your sinus of Valsalva are wide, even if your coronary is 8 mm, the native leaflet will never reach. Now to answer that balloon test, so balloon test on balloon inflation, if the coronary occlusion is not happening, that does not mean the coronary will not occlude during valve deployment. The reason is valve is bigger than the balloon. The only information which you get with balloon testing is if the coronary is getting occluded with balloon inflation, for sure coronary will get occluded during valve deployment. In order to get this answer, either you do a 1:1 balloon sizing. But if your sinus of Valsalva are wide enough, to give you a cutoff, if your sinus of Valsalva are more than 30 mm, you are unlikely to get a coronary occlusion until unless patient has a bicuspid valve. Yes, but great case presentation, and I think it clearly shows how the coronary is low, but sinus of Valsalva are wide and they are filling during diastole. Congratulations again.
Thank you, sir.
Thank you so much, sir, for this wonderful case presentation. May I request to all esteemed chairperson, please present memento to our honorable speakers, Dr. Sohan Sharma. Dr. Sohan Sharma, SMS Hospital, Jaipur. Dr. Danny Manglani from Gitanjali Hospital, Udaipur. Dr. Ramesh Patel from Gitanjali Hospital, Udaipur. Once again, thank you so much to all honorable chairperson. I would like to invite Dr. Ravindra Singh Rao sir for a vote of thanks.
You know what? Thank you, everybody. I can't, I'm really grateful and I'm so thankful that all of you could come, especially a lot of doctors and cardiologists and cardiac surgeons who have traveled from outside city. Thank you very much. And I could clearly see the interest in everybody's mind and heart. And I wish that all of you are able to do these TAVI procedures 5 years down the lane safely and successfully, and maybe earlier also. So this is just a platform to start the program. Thank you very much, and I would invite you all for dinner.